with some.
Yes.
Yes.
Right, good morning everyone, to include members, visitors, press, officers and anybody else that happens to be joining us this morning. Welcome to the Health Scrutiny meeting today, Tuesday the 21st of February. Can I have permission please to sign the minutes from the last meeting? Are they in order? Yeah? Anybody any problems? No? Right. Can I have apologies for absence please?
Yeah, so we've got apologies from Councillor McGrath for other reasons, with Councillor Falls substituting, Councillor Turner for medical illness, with Councillor Butler substituting, apologies from Councillor Martin on other council business, with Councillor Purdue Haran substituting, apologies from Councillor Wilmot on other council business, with Councillor Meakin substituting, and apologies from Councillor Carlin with no substitute.
Thank you. Right, quite a list. Welcome to all the substitute people for today. And I hope everybody's told you that we're here for the full day, so that it isn't a surprise to you. Fine, let's move on. Can I have declarations of interest, please, from members? Yes, Councillor Eddy.
My husband's a community staff nurse.
Anyone else? Councillor Welsh?
Yeah, I'm helping Donna Ockenden with the review into maternity services at NUH, and my case is being investigated by the review.
Right, okay. And I have a daughter who works at NUH. Any officers have any declarations? No? Right, we can move on, everyone. Well, today I have to say I'm particularly pleased to welcome Anthony May, who's the Chief Executive, was Chief Executive here, now Chief Executive at NUH. So it's a special treat to have him back with us today. We also have Chief Nurse Michelle Rhodes, who Councillor and Eddie and I met recently. We've got the Director of Midwifery, we haven't seen you for a while, Sharon, and Chief Operating Officer Lisa Kelly. So welcome to you all, and just so that everybody understands, agenda item 4, 5 and 6 are going to be covered by these representatives from NUH. So, and can we be very careful that we keep our questions to the subject we're actually discussing at that particular moment, and it doesn't get mixed up with something else later on the agenda. Okay? So I am conscious that a lot of members, most of you I'm sure, will want to speak to all these items. So what I'm going to ask, I'm not going to stop and stifle debate, but I would ask that you ask one question and let everybody else have a turn, and then I'll come back to you, just so that we don't have a plethora of questions and it gives everybody else the chance. So, Chief Exec, past Chief Exec and current Chief Exec, it's over to you.
Thank you very much for that welcome. It's great to see colleagues and good to be back. Chair, if it's okay with you, before I start my introduction to the first item, I should like to make a statement on behalf of the Trust. So I know it's a long time since a Chief Executive from the Trust has been here, and it's my intention to engage with this committee regularly. And because I haven't been here since I joined the Trust, I shall say what I've been saying in public when I've made public appearances elsewhere for the first time. And that is to make a sincere and profound apology on behalf of the Trust for any suffering that has happened to people who have used the Trust in respect of our maternity services. We're going to talk about maternity services later today, and we'll explain how we are fully engaged in the review led by Donna Ockenden. But I would like to say from the outset today, as I've said many times in public, that the Trust is sincerely sorry for any suffering as a result of poor services in maternity. We'll talk later about the improvements that we are making in those services, but for now I should like to reiterate that apology.
Thank you, thank you. I think you're giving a State of the Nation report now, aren't you? So yes. Over to you.
Okay, so colleagues, when I joined the trust, one of the things that I set out to do was to understand how the trust works, what it's like to work in the trust, what it's like to be a patient in the trust, and what it's like to be a partner of the trust. And before I joined the trust, I published my intentions in the shape of a 100-day plan, and that was a vehicle to engage people across the trust and associated with the trust in conversations about how we might work together to improve things at NUH, because for very public reasons, NUH has had a difficult time of late, and my role is to try and improve that. So the report that you've got in front of you, which we've called People First, are my reflections on that first few months in post. The evidence base for the report are all the people that I've spoken to and met with since I joined the trust. I totted them up just a few weeks ago when we published the report, and at that stage I'd had engagement with well over 3,000 people, either that work in the trust or who are partners with the trust, and that figure's much higher now. The trust is a very big and complex organisation and employs 19,000 people, and I've made it my business to get out and about and meet as many of those as possible, because at its heart, NUH is a people business, either the people that we serve or the people that work there, or the colleagues that are our partners. And what you've got in the report are my reflections, which I've turned into a roadmap and a blueprint for the future of what is a very important institution for the local area and regionally and nationally, given the extent of the specialist services that NUH provides. There are three main findings from the report, and then a number of things that I recommend that we do to address those findings. And the findings are not new or rocket science, in the sense that I expect when you read the report, they look like a statement of the glaringly obvious. But I think it is important that this report pulls together those statements and our approach to dealing with them in one place, because there currently isn't a roadmap for NUH that does that. So what I've found is there are three things that are barriers to success at NUH. The first is recruitment and retention of staff. We've got about 19,000 whole-time equivalent posts at NUH, which makes it hands down the largest employer in the local area. But at any one time, around 2,000 of those posts are vacant. So clearly, if we're going to provide good and safe services and improve those services for the future, we need to recruit and retain people better. And I'm happy to talk about the way that we might do that as the meeting goes on. The second thing that I've found is that the trust has suffered adversely from its leadership and culture. That's not news to you, because the CQC was very critical of the trust's leadership and culture when it published a report in September 2021. We've done an awful lot to address that in the intervening 16 or 17 months, but there is a lot more to do, and I'm happy to talk about the way we're shaping up the leadership and the culture of the trust as the meeting goes on. And the third thing I've found as a barrier to success is flow through the hospital. By that I mean flow from when people enter the hospital through their journey, either as an inpatient or even as a same-day outpatient, and the way that is affected by pressures in the urgent and emergency care pathways. And we've got a session later on our winter plan, which I hope will help people get to grips with the way we're trying to improve that. But those are the three things that I've found are the compelling reasons why NUH has struggled to succeed in recent years. What I say we should do about it hinge on what I've called a framework of interlocking strategies. The first three of those strategies are what I describe as clinically led, and I've used the language purposefully because there's also a view that NUH has not been led by clinicians in recent years. And of course, clinicians at the end of the day are what people come to NUH for and to see. So I'm trying to put clinicians back at the heart of the future of NUH. The first of those strategies is a long-term strategy for the urgent and emergency care pathway, because at the moment we tend to go a bit boom and bust with a winter plan that we're going to talk about later, when in fact we're busy all year. when I joined the trust in September, we were busy. We got a lot busier during December and January, and we're still busy now, and we'll probably be busy in June. So the point I'm trying to make is that we need to take a longer term view of our urgent and emergency care pathways, particularly working with colleagues in the integrated care system, because so much of what we do depends on partnership. The second of those clinically led strategies is one around what is referred to in the paper as planned care, but sometimes is known as elective care. So people that are waiting for procedures have often been waiting far too long. Some of that is a knock-on effect from COVID, but some of it is because there are too many people in hospital who stay too long when otherwise they're medically fit for discharge. And of course, we've got a close relationship with partners like our colleagues in social care to help us out with that. But if we could free up beds in the hospital that are currently occupied by people who are safe to leave, then we would be more able to catch up on elective procedures, but also get ahead of the curve, because traditionally NUH has been known for the effectiveness of its planned care. And we've got something like 50 odd theatres, and we're still building theatres and wards. And what we're dealing have to do is fill them up every day and every evening and at the weekends, so that we can catch up. And we're doing a lot of that now as we speak. But things like recruitment and retention, leadership and culture, and flow through the hospital have affected that detrimentally. The third clinically led strategy is around what I call our specialised services. NUH's budget is a whopping £1.5 billion a year in revenue, and it has one of the biggest capital programmes in the NHS, and 500 odd million of that budget is for specialised services that people from the local area, regionally and sometimes nationally rely on. And many of those services have been detrimentally affected by flow, leadership and culture, recruitment and retention, to the extent that they are now very fragile and sometimes run on one or maybe a couple of consultants. And although those colleagues are world leading in their field, it can sometimes feel that they're running to stand still. And we want to do something to enhance the resilience of those services, because as well as being important to people across the country, they're also the services where we can forge ahead in clinical practice and research and innovation, and do new things with robotics and AI and technology. So we're going to look at those three strategies over the next few months. It is important that they're in the hands of our clinicians, because then they will feel that they're shaping the future of the organisation. To support those three clinically led strategies, you'll see in the report that there are a series of what I call enabling strategies on things that might sound obvious, but again, they haven't previously been pulled together in one single approach and one single blueprint for the future of the trust. I won't go through those in detail. You can see them in the report, but they include a longer term view of our finances, a longer term view of our asset management and our estates, because we've got one of the biggest maintenance backlogs in the NHS, and yet we're also preparing for a £1.3 billion refurbishment of the assets. A long-term view of our journey to net zero, a long-term view of our inclusion arrangements. You might have seen me in the media last week, because I went to your sister committee in the City Council talking about our efforts to stamp out bullying and racism in the trust. A longer-term view of our patient safety and quality arrangements, a longer-term view of our partnerships, a longer-term view of our digital roadmap, and a whole host of other things that you need in place if you're going to be a coherent £1.5 billion public service organisation. I'm also saying, lastly, that all of that work should be supported by a single methodology for change. There are standard methodologies used in the NHS to change services that promote ideas from the shop floor, from what we call the journey from the ward to the board, and yet we haven't got one of those in NUH at the moment, and we will commission a programme of activities so that we get more ideas coming up from our nurses and our doctors and our physios and our other practitioners on the coalface, because what I've found in those now nearly 4,000 interactions with staff is that they are absolutely committed and passionate about working at NUH, but sometimes feel that they don't have a say, and when they speak up, their voice is not heard. Well, we're changing that. Genuinely, people have reciprocated my invitation to talk and share their views, sometimes very forthright, but always very honest about what happens in NUH, the good and the bad. And we're going to use all of that to improve the services in the future. The next step for the People First report is a full implementation plan, which will go to the Trust Board that signed off People First unanimously in January. And the implementation plan will go in March, end of March, at which point we'll really gather steam and make sure that we follow through with all the strategies. Each of those strategies has got an owner. Some of those colleagues are in the room with me today. They've all got a timeline, and they've all got actions that we will implement in 2023 so that we can keep pace with developments. Now, of course, health services are in choppy waters at the moment. There's no denying that. So the slings and arrows of that, whether it's industrial action, a spike in flu and COVID, the things that we deal with every day, we'll deal with those things every day. But this is about us having a long sight on the future of the organisation so that we can give the reassurance to people like you and the public, and most importantly, the people that use our services, that we can be trusted, and we've got a plan. So with that, Chairman, I'll hand back to you, and I'm happy to take any questions.
Thank you very much. That's a very detailed 100 days. Have your feet touched the floor, Anthony, since you started? I'm surprised. Can I just ask one question? Because you have been talking about, you just alluded to it towards the end of your brief, about the strikes, which I know is nothing to do with you from the point of view and out of your control. How will this be managed with people who've got elective surgery? I know there's a lot of concern out there, and you must know through phone calls, and I realise you don't know necessarily which nurses are going to come into work on the day you strike. I appreciate all that. I mean, the whole thing sounds a nightmare. But those people out there, which are our residents, who are expecting to have elective surgery, do they, if they miss, when the nurses are on strike, if they miss a major operation, how far back do they go down the line before they actually will come forward again for an operation? Because I think that's a big concern.
Okay. As it happens, I've got experts on nurses with me. On the right hand side is Kelly, who's our chief operating officer, responsible for day to day all of our sites. He's going to tell you about how we prepare everything for industrial action, legal and council procedures. Michelle is our chief nurse. I think this is your third or fourth role as a chief nurse, so very experienced. Will tell colleagues about how we manage the interface with our nursing fraternity.
Good. Over to you.
Thank you. So unfortunately, this is our not our first time at going through the industrial action for next week. So we've had quite an opportunity to test out our planning and our preparation, and then our execution of the plan. So as I speak, colleagues across the organisation are looking at what we think is likely next week. So the volume of staff that we expect to see in the organisation, and therefore what activities we can carry on with. By Thursday, we will start to contact those patients that are affected by the industrial action next week. And we are constantly reprioritising those patients. So if you are a clinically urgent patient, you will be at the top of the list. So the clinical urgency determines who gets access to that capacity. You don't go right to the bottom of the list. So the strike action will take Wednesday, Thursday, and into Friday next week. We will then be reprioritising the activity and the capacity we've got available for the following week. So unfortunately, that means that a larger volume of patients are affected or residents are affected, but we're constantly trying to make sure that those that need the services that are most clinically urgent get access to it. If that's helpful.
Thank you. That answers the question. It's clearly a very difficult problem, but that's life, isn't it?
Chairman, would you like Michelle to add something to that?
I'm quite happy for anyone to come in at any time. Yes, please, Michelle.
Thank you, Chairman. Just to say that we've got over 4,000 nurses in the organisation who are RCM members, and we're working really closely across all of the divisions, the wards, the departments, to ensure that everybody has the right to strike. We're absolutely clear about that. It's a very difficult task for us to try and cover, but we have done that so far. So that's what we're working on. But we're working really closely with the nurses to ensure that those that do want to strike, because they've got the mandate, are able to go out on the picket line or not turn up to the wards, which is what happened last time. So I think that the added difficulty this time is this is a 48-hour strike, so it includes overnight as well. So the planning is a little bit more complicated, but we're still working with the teams to make sure that everybody who wants the opportunity has that.
Okay, well, good luck on that, and hopefully it'll all pass without a problem.
Thank you.
Councillor Welsh.
Hi, just on the issue, seems striking has been mentioned. Let's just make it clear that operations are cancelled whether people are on strike or not. And the reason that they're striking is to make a difference to what is going on in our health services. I'm not quite sure why it's been asked in the way it has today. Right, page 18 of the People First plan. There's 3 charts on there where it says patients are waiting longer in our emergency department. The number of patients who are fit for discharge but are still occupying hospital beds has been increasing since the pandemic. Our waiting lists have been growing since the pandemic. This combined with the ongoing use of the private sector, so a lot of people that have CT scans, colonoscopies, are being phoned up and getting a choice between 3 different private hospitals in Nottingham. Where realistically do you see this going in a year's time? We're talking about record times of waiting in the emergency department, people waiting in hospital beds when they should be discharged into social care. I think it was 300 at one point, wasn't it? And waiting lists are growing, and not only waiting lists are growing, things like colonoscopies that should be done within 7 weeks after, I think, are not being done until 12, 13 months afterwards, and that's about early intervention with regards to bowel cancer. There's obviously some real, you'd probably call it serious challenges, I might call it something different, and there is a whole scale use of the private sector as well, which must be costing the trust a lot of money. Realistically, how do we get out of this? Because I can't see a word out without fundamental change of really NHS and what it's doing. But how will NUH realistically get out of the fact that in an emergency department you're waiting 16 hours? We've seen reports in the paper. My father was left in a corridor, for hours on end. When are we really going to see a difference? And with all the will in the world, I've read this plan. I think it's a really great improvement plan. There's nothing against what is in there. What I'm failing to get the grasp of and failing to see is how any of that is really going to make a dent with regards to this. And as Councillor Saddington has alluded to, nurses have been on strike for the first time. We're seeing junior doctors coming out. We've got ambulance staff going out on strike, all in my opinion for very valid reasons. So where realistically is this plan going to reduce these times in the emergency department, and when will people not be waiting in corridors for hours and hours on end? When will that happen, and how will that really happen, Anthony? Because I don't think that this plan is going to make that happen. That's what I think. I think the problem is far greater than an improvement plan. So I'd like to know what your take is on that, because the emergency department comes up a lot with me with regards to residents, as does the ability to get somebody out of hospital into social care. Nobody, and I know that you don't want this, Anthony, because I've known you for a lot of years. I know that you wouldn't want people waiting in corridors, and I know your staff wouldn't want people, but it is happening. And it's quite frightening to see in this day and age, in this country, old people waiting in corridors on beds. So when will we really start seeing that change, and how will that change? And what are you doing as chief executive with regards to knocking on the government's door to tell them that we actually need some fundamental change in order for us to improve our services at NUH.
Oh, sorry. At a strategic level, which is the worst way to start an answer to your question, I think this will improve NUH. On a day-to-day level, clearly at the moment, this paper in itself is not going to make the step change that we all want to see. And as well as apologising at the beginning of this meeting to anyone who suffered as a result of poor standards in maternity services, I should also like to apologise to the people that have been waiting too long, whether they've been waiting too long in ED, sometimes in unsuitable environments, or whether they've been waiting too long for a planned procedure. We want to improve that. I genuinely think, and so do people in NUH, or those that have contacted me and engaged in this, which are in the thousands, that this is the medium and long-term way to improve that. Each of these strategies does have a set of objectives in 2023, but I appreciate that isn't changing things for your dad or others that are on the corridor in ED. I've spent a lot of time in ED, and I agree with you. We have got operating procedures to make sure that people are safe no matter where they're cared for in ED, and they're fed and they're cared for properly, but it isn't what ED was designed for. And we want to move people through the hospital quicker, and we want to discharge them. It isn't just a social care problem. Quite a lot of our discharges are either back home or they're into community settings that are not commissioned by social care, so it's a whole system issue. I'm regularly in contact with colleagues at the region in NHS England. Because of our place in the Ockenden Review, I probably speak to them more than more than I otherwise would, and we are constantly feeding back the ways that we think this could improve. Things like industrial action and the structure and the future of the NHS. Well, we do what we can, and there are provider networks that we're involved in that also do what they can in the same way that the county council network does. But on a daily basis, we're focused on making it safe and better as far as we can. So Lisa might want to add some of the stuff that we do to mitigate some of the things that you've described, and then I think we'll probably get into it in a bit more detail, particularly the winter planning stuff on the third item.
Perhaps if I just take a couple of practical examples on discharge. So one of the things we've introduced over the last few months is what we're describing as NUH at home. So where we've got a delay and we perhaps can't access the social care as quickly as we need, we have got a programme where our healthcare support workers are going out into patients' home and doing some of that care, perhaps for 3, 4, 5 days a week even. And we've seen that reduce since the beginning of January, 86 bed days. So that's released patients waiting that otherwise would have waited in those hospital beds. We've got other opportunities as well to work with our partners in community care and in local authorities. So we're constantly trying to build and work together on how we make best use of the capacity. So we've had new monies come down nationally that we've had a proportion of that in Nottinghamshire. So working with them on how best we can figure that and how we can support discharge. And then perhaps just another example about how we're keeping people safe in ED. So ED is more crowded than we want it to be. There are more patients there, and we continue to offload the ambulances even when it is already busy in the A&E department, because we know that the data tells us that it's safer for those patients to be with us than it is to be waiting at home and having rang 999 and having a delay of the ambulance coming. So we balance that risk, and we work really closely with the East Midlands Ambulance Service. But we also have additional clinicians coming into the organisation. So one of our deputy medical directors is leading an InReach programme where we've got the specialists coming into ED to make sure that we've got the plan correct for them and we're giving them the support and treatment they need whilst we're waiting to move them through the hospital. It's not an absolute science. It's not where we want to be. It's not the care that our colleagues in the emergency department want to give. But there are a number of ways that we're trying to ensure that the patients, when they're there, that they're as safe as they can be, and we're supporting them as well as we can.
Thank you. Councillor Fole.
Yes, thank you, Chair, and thanks for coming, Anthony and Lisa. And it was a very interesting plan. It's good to be back here. My question, I've got a series of questions, but they're all related around culture, leadership and culture. I think it's good that you've entitled this People First. Clearly, it needs to be, didn't it, really? When you read some of this, again, for me coming into this kind of relatively new, it is absolutely shocking, some of this. I mean, just to quote a little bit, not too much, 41% of staff felt confident there is concern they will be listened to. So less than half feel they're not being listened to. You've already made reference to bullying and racism, Anthony. It's absolutely appalling. And then you found we aren't canned under pressure. And of course, there's safety issues as well. So there may be more than one reason than pay why nurses are on strike at the moment, I guess, might do. And I think, again, there's the issue about detachment from decision making and the too great a distance between the ward and the board. I remember when I was kind of sitting where Sue's sitting about 2013-14, and remembering a nurse who worked in A&E had actually been given some money to do a little bit of research to find out what was going on in E&D. Now, in 2014, it's completely different. I'm sure no COVID, no nothing. But what he'd done is identified, I think it was 50, of the real kind of people that kind of were in E&D every week, or kind of 2-3 times a week, worked out what the problem was, worked with the families and reduced it hugely and took an awful lot of pressure out. But despite what we did, and I'm sure Sue would have done the same in his role, I wrote and said, can we have some more funding for this? And we tried it, he didn't get it. So I think, it's those kind of ideas, because as Anthony's already said, there's some really good work going on in there. They know what's going on, don't they? In some respects, better than you will by just talking to them, won't they? I mean, that's bound to happen, isn't it? So I just want to ask a little bit more than about the cultural change and how this is going to get better. So the role of leadership is absolutely key here. So who's responsible for cultural change, Anthony? And how confident are you that the current board is 100% with you? I don't know how many of the old board that led us into this kind of situation still exists, and how many new people there are in the board. But I would need to be reassured that all the board are with you when it comes to kind of cultural change. And also with senior management. I mean, you have some very long-standing senior managers in here that, again, have been here throughout what's been a very difficult and issue for the National Health Services. I mean, are they with you? Are they ready and willing to make the changes needed?
Of course, please. Just make yourself at home. Just make yourself at home.
Sorry, Anthony, you can use your mic. Let me go back to the hardcore issues here about how people feel and how they feel they've been treated. So there was a reason we took the report to the City Council Scrutiny Committee last week, and I spent so long with Anna and other colleagues in the media, is that to me it's utterly abhorrent and completely unacceptable in 2023 that somebody should come to work and be subject to racism. And when I joined the trust, we were using all sorts of different language to describe what I see as racism. Now, anybody who's bullied or harassed or discriminated against for any reason at work deserves to be treated properly, and for that issue to be, first of all, nipped in the bud, and secondly, sorted out properly and sustainably. So we're doing an awful lot, particularly with the support groups. We've got support groups in the trust, just like you have here in the council, and they are absolutely bought into this, which to me is as important as the board buying in. And I took two of those colleagues with me to the City Council Scrutiny Committee last week, and one of them told her story in the meeting. It was really powerful stuff. So partly it's about encouraging people to be honest about their experiences, good and bad, but also to hold people like me to account if, when they raise stuff, it's not getting dealt with quickly enough. So we've brought in a new director of inclusion who starts in May, whose job will be to lead on all of our inclusion arrangements. In People First, we've committed to an inclusion policy, a trust-wide inclusion policy. The leadership of our inclusion arrangements will go to a new member of our executive team, who is a prominent black leader in the NHS, who started with us at the beginning of February. And Gilbert will make sure that he flies the flag for these issues, he uses his national contacts, and that we really double down on stamping it out and then encouraging people to express themselves at work and fulfil their ambitions. Because, first of all, I think we should celebrate diversity, and secondly, it's good for business. Because if our workforce is reflective of the community in which they live and feel happy at work, they're just going to do better. So, to me, cultural issues that we face always come back to whether people feel safe working at NUH, and I genuinely believe that they feel safer now than they have done previously. And a lot of that work started before I joined, and I think we'll see some modest improvement when the National Staff Survey is published on the 9th of March. Modest, and I hope to see much more improvement next year. And we're working really hard on that. And we've set up a subcommittee of the board, which reports up to the board and is led by one of our new NEDs, Sergio Kaur, who is an Asian colleague who's passionate about inclusion. And Sergio will be supported by a new associate non-executive director, and we are unashamedly targeting people who've got experience in inclusion. So Sergio will be joined with another non-executive director and is leading a committee that will fashion and work up the inclusion strategy for the whole trust. And that committee is populated by people who represent the workforce. And we had a workshop last week, which was really, really good. So there's a feeling that we've turned the corner on this, but of course what really matters is people's day-to-day experience. At board level, there are new board members, both at non-executive level and at executive level. We're recruiting for new board members currently, some substantive. In fact, I think we filled a substantive one, and some non-substantive, so we call it associate directors. So we are seeing some new faces around the board, and they are more representative of the workforce and the local community. Also at the executive level, because some colleagues are retiring or inherited some vacancies, we will have 4 new colleagues on the executive team, all replacements, not new jobs, and a 5th one later in the year. I have to say, though, that having worked with the existing executives in the time that I've been there, those colleagues are as committed to improving the trust and as regretful about what's happened in the trust as I am. But we are seeing turnover in the team, and the team will look very different in even just a few months' time. And I think that is important because whilst I do value the experience of the incumbents, it's also good to have some fresh thinking because people in NUH have worked extremely hard through difficult times, and getting some new and fresh perspectives in the trust is a good thing, particularly people who've worked in other parts of the NHS. So I think we've got all of that in place. As for where the locus sits for this, well, of course, the board is ultimately responsible for everything that happens in NUH, and they unanimously supported people first. But I will personally lead the culture change in the organisation. I've been meeting with colleagues, particularly colleagues who feel they've been bullied or the subject of racism. I think they've appreciated that. We're putting more resource into our HR service so that we can support processes better, and we're reviewing and evaluating the processes to make sure that they work for people. We've got what we call freedom to speak up guardians, where people can take their concerns if the line management system isn't working for us. We've got what we call BAME ambassadors and culture ambassadors that are on the shop floor, where people can go and talk to those colleagues if they've got concerns about their working environment. And we've got all sorts of other really helpful initiatives underway, including some senior colleagues from the nursing part of the trust, because we've got nearly 8,000 nurses who are leading on inclusion and do represent their workforce, and also represent international colleagues. Some of those colleagues have come in from overseas because of a lot of international nurses, particularly. We've got international colleagues across the trust, but particularly in our nursing cohort, and we're actively recruiting from overseas. So we want to make sure that those people not only have a good welcome at NUH, but also in their communities. So we're working with the City Council and others to make sure that they can integrate properly into their communities and get the right support services so that they can live and work happily. So we've got an awful long way to go on this. And truthfully, as I said at the City Council Scrutiny Committee last week, we shouldn't have needed an inspection to tell us that this wasn't right. But in the end, I can't turn the clock back, and neither can people that are still there from that time. What we can do is use this as a vehicle. I'm acutely aware, because of all the years that I had here, that these things just gather dust if you don't actively implement them. But for what it's worth, that's what we're going to try and do.
Thank you, Anthony. Councillor Meakin.
Thank you, Chair. Can I firstly welcome Anthony back to the council? Good to see you back. The Nottingham University hospitals face significant challenges like other major NHS trusts. This includes Sherwood Forest Hospital's NHS Trust. Councillor Dave Martin, who's on other business this morning, has asked me to ask whether it is possible to get Paul Robinson, of the Chief Executive of Sherwood Forest NHS Trust, to a future meeting to discuss future health challenges at Kingsmill Hospital, Newark Hospital and Mansfield Community Hospital. An ongoing concern at Sherwood Forest Trust is the ongoing PFI scandal. This is costing the trust over 1.2 million a week in debt interest before a single payment is made to clinicians, nurses and other staff.
That's actually a work programme issue, Councillor Meakin,
Okay.
and Sherwood Forest Trust is different from NUH. So I think I would raise that, unless Anthony particularly wants to say anything, but I would raise that under the work programme because that's where it needs to come in.
Thank you.
Okay. Did you want to make a comment?
Yeah, not about the PFI. I don't, apart from when I've worked here, I don't understand the back and forth with the PFI. What I can say is that I'm the sponsor of a system-wide piece of work called the Partner Provider Collaborative, which is where the large providers, so EMAS, NUH, Sherwood Forest, Doncaster and Bassett Law, and the Community Health Trust have come together to see whether or not we can share resources and do things for each other in pursuit of better patient care and safety. So Paul Robinson is an active partner and player in that. I think that's got great potential, and I'm sure Paul, when he comes, will talk to you about what he's doing at Sherwood Forest.
So we will put that on the work programme, but you can raise it again later in the day. Councillor Anderson.
Thank you, Chairman. I'd just like to ask about the basics of attending hospital appointment. I'm someone that has numerous medical conditions who attends appointments at several different hospitals, including the City, the QMC, Royal Papworth, the Transplant Centre. So I receive numerous hospital appointments. I brought a few with me today just to illustrate that fact. And when they arrive, it says, your consultant, nominated nurse or one of their team, clinic, C-JD61A, and then it tells me the time. So it doesn't give me any further information than that, other than, well, I have to ring up and find out where the appointment is, who I'm supposed to see, and what the appointment is actually for. So it can be quite unhelpful. I had 3 different appointments, like I say, last week. Then when I go to the appointment, if it's an in-person appointment, the first thing they ask me when I sit down is, what medications are you on, Mrs. Anderson? So I have had the same medical problems for over 25 years, and I've been on predominantly the same medication for 25 years. So I'm on approximately 80 tablets, 3 different nebulizers, 2 lots of insulin, inhalers, all sorts of stuff. And that information that I have to relay at every appointment eats into the time that I'm allocated for that appointment, and then the rest sort of has to be rushed because the time is being used up. I just still find it baffling that people that I have the appointments with don't have access to this sort of information before I attend. The next bit moves on to what operations and procedures have I had recently. Again, that's another extensive list. So to be fair, I'm lucky if I get to discuss my conditions at all with the person that I'm having the appointment with, and I just find it incredibly frustrating. Thank you.
Thank you. I'm sure my colleagues will contribute to this, but so I recognise all of that, Sinead. And next time you're in QMC or City and you get lost, if you bump into me, we can be lost together because they are confusing sites. to get around. So some of those basics we are looking at. We're out to advert for a new director of communications at the moment, and the acting director, Jack Adlam, who's here with us today somewhere. There he is, over there. And I are looking at some of the basics of wayfinding. How can we get people around the sites more effectively, because it is confusing. We're also looking at things like correspondence, because Lisa and I came across a patient last week and I looked at the letter and it wasn't clear to me where that person was destined for. And then also we're looking at things like electronic patient records to see whether or not we can stop people having to tell their story multiple times. We've got some money to develop our electronic patient records system. We have got a really good internal system which helps us. We've got a good view of the site and how people are moving around the site, which is where we get our data from around flow. But at the moment, it doesn't translate to a single view of a patient record. One of the new executives that we've just appointed, started in January, is a chief digital and information officer. And his job, his name's Andy Callow, is to try and bring all of those systems together so that our clinicians who get as frustrated as you have a single sight of a patient, don't have to keep asking them to tell their story multiple times, and can see at a glance what the medications are and so on. The other thing that we're doing is we're rolling out a pilot on electronic prescribing, which means that we can prescribe, it does what it says on the tin, without using the pads, and once it's done it goes straight into pharmacy so that people wait less for their prescriptions, because colleagues like you who come along regularly find that they spend a lot of time waiting. And when I talked earlier about people waiting too long, that isn't just people waiting for their treatment, it's people waiting for transport, prescriptions. So those things they're part of this report, and we are trying to improve things on a daily basis as well. But I'm sure that Lisa and Michelle would want to add to that.
Could I just add? I'm really sorry. If you're confused, somebody that manages their health conditions, obviously as well as you do over such a long period of time, then our older generation and some of our other more vulnerable patients will also be suffering from that. I can't add to the list that Anthony said because how he's remembered it all, I don't know. But in one by one, he's laid out all the things we're doing to try and make that better. I'd be really. It would be really helpful if I could have a copy of the outpatient letter that the bits that you just said down the side, because that'd be really useful for us to absolutely feed back into the work that Anthony's doing. But you should be able to spend the time when you're seeing your consultant or your nurse specialist talking about how you feel, not about what's gone before that's been gone for the last 20 years. So I'll feed that back. I have the complaints and the power service as well, and I'll pick that back and feed it back to everybody.
Thank you.
Thank you, Michelle. Councillor Butler.
Thank you, Madam Chair. Well, it's good to see you back again, Anthony. You like a challenge, don't you? And you've certainly got one here. And 100 days. Has it gone quickly? Yeah, I thought it would do. But with regards to the flow issues in particular, we're all aware of the pressures on A&E. I mean, I do sometimes wonder whether the A&E is unnecessarily stretched, because are there still too many people turning up at A&E when they really don't need to, and therefore putting a barrier in your the way you do things. And if that's the case, there must be a way of somehow getting a message across to people that even nowadays, despite all the press coverage you get, don't go to A&E unless it's a real emergency. But I would imagine people do, and I'm sure you'll confirm that. But that said, I know there is a problem in A&E, and it's your big priority, or one of your big key priorities here, is to try and find a way through it. As you say in your report, you can't do it all yourself. You've got to work with the other agencies, both within the NHS and also externally. How confident can you be that this can happen? Because or how will it happen? Because at the other tiers of the NHS and the other services, they've got their own challenges as well, and so they're no doubt having the same sort of thoughts and challenges you've got to resolve their own problems. How can you get the commitment in from the other players that they are going to manage themselves or do what they have to do to ultimately help what you need to do and your colleagues need to do. I would imagine it's a really big ask, and I'm not sure how best you can do that. But
the work across the partnership is more mature now, I think, than I've seen previously. And bear in mind that because of my various roles over the years, I was one of the founding members of the STP way back, probably 10 years ago, when we were just sort of feeling each other out and getting a sense of what we could do together. Since I've joined NUH, I have been impressed by the way that all partners in the system understand the problem, want to get a single version of the truth, because data and the way that we count things can be variable and can confound progress. There's a lot of work being done to make sure that we've got a single view of the data, and also that we understand each other's roles and responsibilities. So it won't surprise you to know that when I first joined the trust, people thought that I might be able to wave a magic wand and make social care work. And of course, social care is in itself very complicated and has its own difficulties, as you alluded to. But bit by bit, the system, I think, is coalescing around a number of key areas, particularly the urgent and emergency care pathways. And there is, as you say, a value chain, for want of a better phrase, through that starts at prevention. What can public health do to enable people to live more healthily at a population level and a community level? What can our primary care colleagues do to help avoid hospital admissions or attendances? I have to say that primary care work really well with us, but I think it's a little known fact that I think the city of Nottingham and Nottinghamshire has probably 700 or 800 GPs, and in a place like NUH, we've got 19,000 staff. So the GPs have got a lot of work to do, and people attend GPs regularly now in the way that perhaps you and I, when 20 or 30 years ago, we didn't. So I think the whole system is only going to work better if it works together, and I've seen good and positive signs of that. But I also think that, truthfully, there's a lot more to do. I think the work that we're doing on the urgent and emergency care pathways, particularly urgent treatment elements of that, which are where we can contribute to the bits that fall between primary care and secondary care, will be extremely helpful in preventing people coming to hospital. The work that we're doing in the hospital on what we call same-day emergency care, I think will help get people out on the same day, because the longer people are in hospital, the more likely they are to decondition. The work that we do to treat people at home, whether it's what we call a virtual ward, where people are at home but they're monitored with this sort of tech, or whether it's hospital at home, where people are at home and they get care before they step down into independent care or social care. All of those little things add up to eventually, hopefully, getting that step change that Michelle was asking for earlier. But it is like that, the much fabled story of incremental gains. There's no one giant leap forward in this. But given that, as Michelle said earlier, we saw record attendances at ED over Christmas, and we don't want to see that again. I think there is a new impetus to try and resolve this at every part of the system, and not just see it as either social care's problem or NUH's problem. And I hope that we get that kind of support and backing from other partners outside the ICS as well, because we just signed an MOU with the University of Nottingham, because they supply us with a lot of our medics and nurses. And it's really important that we work with our institutions like the University of Nottingham and Nottingham Trent, because they can also help us with innovation and technology and artificial intelligence and predictive analytics. So this is a whole system initiative, and each bit of the system can contribute, and gradually I'm convinced that we can work this out, but it's a long-term proposition. This is not going to happen overnight. So.
Thank you, Anthony. Councillor Pershue-Harden.
Thank you, Madam Chairman, and welcome back, Anthony. Good to see you. You won't be surprised that some of us have been knocking on doors recently. Some of us get the hairdryer effect from some residents, and others are quite pleasant. But a lot of them have raised the same issues. And it's not just myself, but other colleagues have received the same questions. And my colleagues and I, we quickly came to the conclusion over a pint that Bingham has a bit of a health crisis. And we were wondering what the effect is on frontline services at Nottingham University hospitals. Residents have told us that it takes ages to get an appointment at Bingham Health Centre, and that story, of course, is replicated elsewhere. In November 2021, the former Health Secretary, Sajid Javid, spoke to the House of Commons Health and Social Care Committee, and he blamed a lack of GP appointments for increased pressure on A&E departments. Would you say that the lack of GP appointments is adding pressure to NUH? And just so that you are aware, we thought we had the bizarre situation late last year where two parts of the health service were giving out contradictory advice to the same people. During the critical incident declared in late December, NUH were begging people not to present themselves at A&E. But my colleagues were telling me that Torquard Hill Medical Practice in Hucknall were telling residents in the most difficulty to make their way to A&E if they couldn't get an appointment at the practice. And this advice, I understand, is still on their website with the line, and I quote, "Over the past few weeks, we have had the equivalent of one GP managing over 100 plus patients each day. This level of work is something that would be unimaginable in any other NHS service, including A&E, walk-in centres and GP out of hours," close quote. So do you believe if GP practices like Bingham and Hucknall received more in terms of resources, would that take the pressure off NUH?
Councillor Purdy-Horan, Anthony might like to answer that question, but if it's about health centres and primary care, it needs to come in this afternoon's meeting when we're actually talking about access to GP surgeries. But if Anthony wishes to say something now, that's fine.
Forgive me, Madam Chairman. I did see that, and I think actually my question was more towards the NUH issue.
So okay. I'm happy to pick it up.
All right.
Chairman, and we've got my colleague Rosa Wadding, the chief nurse at the ICB, with us as well, who might have wanted to say something about the previous question as well.
Yeah, so, Rosa's down to speak next, actually. So whether you want to bring her in earlier, Anthony, it's up to you.
We're working really closely with our primary care colleagues, including that surgery in Hucknall, actually, where some of my colleagues are going to visit in a few weeks' time, to make sure we understand each other's perspective on this, because in a very stressed system, of course, there is a tendency for not to understand each other's roles and responsibilities, and primary care play a really important part in the whole system. As I said, there's a limit to what they can do in the same way there is to any other part of the system. So we want to understand, we want to improve our communication with primary care, because they tell us there's a lot more that we can do. Some very simple things, correspondence, access to records. So we think we can do a lot to help primary care as much as they can help patients avoid coming to hospital. I do think that urgent treatment strategy that I mentioned earlier, which we've had a meeting about this morning, can be really helpful. We've got urgent treatment centres dotted around the county. That's where people can go rather than primary care or secondary care. I think if we can make better use of those and get the word out, there are places that people can go and they will get good treatment. That might avoid attendances in secondary care. All of the things that we're doing in NUH to increase throughput and flow, I think will help the system generally, because I'm sure that our primary care colleagues are seeing the effects of people waiting too long for their planned procedures. So we need to assist them with that, because it may be that we can take the strain off their appointment list by getting people in quicker and out quicker, and crucially, make sure that they're prepared for their procedures. We do a lot of work on pre-operative support, and that when they go home, they can go home safely, so that they don't need the support of their primary care, the local primary care services. I do think you make a really good point about communications. And during things like our critical incidents, which no doubt we'll talk about later on when we get to the winter plan, we work really hard on a daily basis to coordinate communication so that we give a single message to the public. All of those things I'm absolutely sure contribute now, but we can do better. And Chairman Rosa might want to add.
Yeah, I was going to bring you in next, Rosa. Thank you for coming, and it's lovely to see you again. Thank you.
In response to both Councillor Butler's question and the points you raise, to endorse what Anthony said, no man's an island and certainly no hospital. So we recognise the interdependencies within the system around pressures, but also the work that Anthony's outlined in that People First plan will impact on the pressures being faced elsewhere across the system. We are working together more closely. I would recognise the picture that Anthony paints of much more integrated working, people lifting their heads up, and certainly NUH to be much more part of that system conversation. And Lisa gave a really simple but great example earlier on of the fact that however pressured ED is, a 999 call that can't answer, somebody having a heart attack presents a higher level of risk. Those are conversations we have. We don't work in silos in the way that perhaps we have done historically. We talk about that and understand that and try and manage those risks and our responses collectively. So I would agree there's still lots to do and lots more that's possible, but the strategy that Anthony's outlined in People First is going to be an enabler to get all of us there in that system space, as are things like our integrated care partnership plan that colleagues will have been involved in developing, so we can have a single population centred set of aims and objectives moving forward.
Thank you, Rosa. Councillor Micah.
Thank you, Chairman. Yes, I want to focus a little bit on the digital side of things. You talked about AI being introduced, and we're looking at analytics across the organisation as well, all things I've utilised in the past. But this is an emerging industry in tech, and we're just starting to understand the opportunities that it provides. But I want to take you back to a basic, and it's something I was prompted by what Councillor Anderson raised around the process of appointment. Currently, if you want to cancel an appointment, you have offered a telephone number to dial through. I mean, that feels 2003 at best. What I'd like to understand is, in this new director post that's being introduced for digital, how are you going to extend that ability for people to be able to use multiple mediums that are more comfortable to the majority, specifically 2000 onwards, let's say, so that we're able to free up those people that are locked in appointments and unable to contact through and cancel them as quickly as possible, to free up those queues for people that do need the appointments, can attend on the day, which hopefully will ensure that the flow improves, because it does, like I said, if you're stuck in that queue or you get an engaged tone, that's it. You can't cancel it, and it will just go and it will fall, and then you get a letter back telling you off for not turning up. But if you can't get through, I don't know what you're meant to do. Thank you, and nice to see you.
Thank you. Yeah, nice to see you, Mike. Thank you. So Lisa will help me out with this, because she's passed the baton to Andy, the new Chief Digital and Information Officer. What I would say at a trust-wide level is that I recognise that our communication is inconsistent and sometimes frustrating, and we are looking at how we can improve it and how we can improve it using technology, because there are simple solutions here that we can deploy that ought to resolve some of those things, and it absolutely is Andy's job to do that. He's very experienced. He's been a chief digital officer at another trust. In fact, he was their acting chief executive, so he's been around the block. He also worked in local authorities, so he knows his stuff. He's got a mountain to climb in terms of making sense of such a complex organisation with so many, sometimes competing systems, but I've got every confidence he will. In the People First report, you will see that there's a digital strategy that Andy will oversee. He's already on with engaging with our clinicians to make sure that they can see themselves in that, because our clinicians also want to see change, particularly multiple systems, multiple logins, and a lot of our clinicians are very tech savvy by their background and their nature, so they're going to help him make sure that we can plot our journey through the systems using a clinician's eye, but also using a patient's eye. We've got a very strong patient representative group that works really hard to understand the point of view of patients, and it's going to work with them to see what it looks like to navigate the trust from a patient's point of view. I'd like to think, particularly as we get into the tomorrow's NUH era, where we start refurbishing our premises, that we can look at things like augmented reality and digital wayfinding. Now, not everyone uses a smartphone, so we're not going to be able to eradicate normal wayfinding, but there's lots of stuff we can do to make the place just more navigable. Lisa, you might want to add stuff as well.
Just a few practical things in terms of what we've been doing over the last year. So we have text messaging. It's not consistent across all of our services. We have an app called Doctor Doctor, which does enable you to like change your hair appointment online and the way we do banking. We've also just started a pilot around email communication. So if you don't want to receive by letter, are you happy for us to use your email address? So there's a number of pilots that we've got happening, and some of that has grown up bottom up from those services, sort of saying that there's got to be something better. I think the addition of this board post, so having someone, we haven't had this role before, having Andy in post gives us that opportunity to really describe that digital roadmap. There's a whole section in that that's about what are we doing technically for our patients. So there's something about how do we make it easier for our staff to use and manage our data and use the tech available. But there's a whole focus around, and we've had a number of kind of tests about what we think is the best and what's working well, and it's different perhaps for outpatient appointments as it might be for others. We've got a really good example in the implementation of Badgernet, our new maternity system, where patients can interact directly with their clinician in terms of that communication. So I think we're at a great point now of pulling that stuff together and being really clear about what that looks like for our patients and how do we create that consistency across the organisation over the coming couple of years. So lots more to do in this space, and a lot of energy, as Anthony described, in the organisation about what the art of the possible is.
Thank you. Members, I've got two more people who've indicated they wish to speak, and then I'm afraid we're going to draw this item to a close because we've nearly taken 100 minutes to discuss 100 days. So I think we need to be drawing this to a close and moving on to the next. So I've got the Vice Chairman, and then I've got Councillor Welsh coming back, and then we'll draw it to a close. Okay, if everybody's all right with that.
I was polite and didn't. I do have another question, because you did say we could ask another question.
You want another question?
Yes, please.
All right, after Councillor Welsh.
Thank you.
Vice Chairman.
Thank you. I'm just going to bring it back to the recruitment, just because my husband's a nurse and it's something that's that I care quite strongly about. I was really happy to see that one of your priorities is a well-supported workforce. You did also mention that you had 2,000 vacant posts in your introduction. And then on page 19, you've put success needs to be measured over the coming year in terms of the time it takes to hire staff and the number of vacancies. What do you see that going down to in the next year or so? And what actually do you see is the minimum to make it? And I think on page 18, you put the right number of people at the right time. So how does that correlate? And how many people do you need to make it the right people at the right time? I think that makes sense.
It makes sense to me. Well, they're quite difficult to answer, I have to say. I'll give it a shot though, and then Michelle will probably want to say something about recruitment and retention because it's an area that Michelle spends a lot of her time on. So let's first of all take the big picture. How are we going to sort all of this around recruitment and retention? So I'm leading a dedicated recruitment and retention working group, which has split its work into 4 themes. Our recruitment processes and our retention processes are 2 of those themes. I've got the others in my notebook, I'll find them in a moment. But the reason we're focusing particularly on those 2 is because actually recruitment we don't do too badly on at the moment, but we know that we can improve it because it takes too long from offering someone a job to getting their feet under a table or their feet on a ward. As for where we're headed, I spoke to Neil Pease, our Chief People Officer, last week because I've asked Neil to amend the estimated time for time to hire, which I think is currently in sort of 60-day territory, and I've asked Neil to give me a plan to get it down to under 40. Now that's a mixture of external recruitment and internal recruitment because quite a lot of the people that get jobs in NUH are moving from one part of it to another, and we're trying to affect time to hire from both an external point of view and an internal point of view. We have a business case in train, which has not yet been approved, so I should caveat that, to invest more in our recruitment team because the data is against us on this. 10 years ago, we employed 12,000 people in the trust, and now it's 19,000, and yet we haven't increased our investment proportionately in our HR service. So it's no wonder they're on the back foot. So we're doing that now. We've also employed a new director post in HR, and that colleague, she's called Natalie, is specifically focused on recruitment and retention. And she's brought in a lot of new ideas, including the use of technology, because we do use a lot of AI in our recruitment pathways, actually quite successfully. And we think there's more that we can do, but in order to make it optimal, you've got to sort out the basic processes and systems because the AI is only good if you've got really good basic fundamentals in place. So if we get all of that in place, I would like to see that time to hire come down. I think colleagues might remember this better than me, that Neil has given a commitment to go back with a revised time to hire target to a future board meeting.
Yeah.
So that's where we'll say publicly what that new target will be. If we got it down to somewhere around 40, we would be probably a little bit better than the average NHS institution, which is a really good thing. On retention, I have to say that we're already doing a great deal, but there are also some things that bedevil us. So some of the things that work really well, we've introduced a £2 meal deal where you can get a meal for £2. People work 12-hour shifts. They're on their feet for a long, well, you know this. And sometimes they don't get very long to go and get their food, and they want something hot. So we've made that much more affordable. We've changed some of the queuing arrangements. We brought in additional staff. I have to say our caterers, who are arm's length from the trust, are taking a hit on their turnover for this. They've been brilliant, actually. That's gone down the storm. I'm working every single day on the MediLink service, which is a bit of a curate's egg. More eggs than curate some days. And we're working really hard with the City Council, who commissioned that service with us to make it better. Actually, in the last week or so, we've had 100% journeys operating, but we've been dogged by roadworks. But we are actively managing our integrated transport offer because so many people complain it takes too long to get in and out of the sites, and it lengthens an already long day if you're working 12 hours. We're also just about to reissue our car park permits because we've got less than 3,000 available car park spaces and about 9,000 people who want to use them. And we've gone through a process using a criteria that colleagues came up with through our big conversation engagement piece of work last year, and hopefully it makes it fairer and more accessible and recognises people who need to be on site and recognises clinicians because those colleagues often need those car park spaces perhaps more than some others. So we're going through all of that, and we're doing a lot of work to support people through the cost of living crisis. We have fruit and veg stalls on the sites where people can come along and get good quality, nutritious food. We're providing them with some advice about how to manage their finances through cost of living. We partner with Experian to do that. It's a really innovative piece of work. So we're trying to do everything we can to make the recruitment process better, but also to retain people when they're here, including things like access to water stations. People complained that there wasn't enough places to go and get a drink, and both hospitals get really hot in the summer, so we've rolled out new water stations. We're looking at rest areas. We're just about to prioritise bids for rest areas because people complain that there aren't enough places for them to go and sit and have a chat with their colleagues and have their lunch, that kind of stuff. We've also got a really good cultural programme across the trust where people can engage with stuff just to take their mind off work. We run things like Schwartz rounds where people can come along and talk about their practice. I participated in one yesterday. It's an opportunity for people to share stuff in a safe space, stuff that's gone well and stuff that hasn't gone quite so well. So we're doing an awful lot. There's a lot more that we can do. Michelle might want to say something specifically about the lengths that we're going to recruit nurses.
Yeah, so when it comes to the numbers of nurses on the wards and across the organisation, we've got about 450 registered nursing vacancies, and about 150 healthcare support worker vacancies as well. So there's a lot we can do about that. And Anthony has spoken about the time to hire thing, because that's one of the biggest issues for us as far as getting nurses in, because they have a choice to work wherever they want across the East Midlands. There's always vacancies. So Derby's, for example, their time to hire at the moment is better than ours. So if you've got an offer from Derby, you've got an offer from Nottingham, and it doesn't matter which way you go. If you're more quickly to get into Derby, some of our nurses are going there. So that is a big thing for us. With regard to the numbers on the wards, we twice a year I take an establishment review paper to our trust board, and that's a nationally mandated paper. The National Quality Board expect the chief nurse of organisations to do that. So that went in January this year, and what it showed was that the funding that is available for nursing, healthcare support workers and midwives is enough. So there is enough money in NUH to provide the numbers of nurses that are required on the wards, but unfortunately vacancies and sickness has meant that the numbers are down. So Anthony's talked about all the things that we need to do, and I think the one that we've got to really focus on for nursing is flexibility. So it's such an issue. I'm sure if your husband works with us, you know that it's a real issue for nursing staff, midwives, about just them being able to work shifts that fit around with their home life as well as with the services that they work for. So it's something that we're really keen to do. At the moment, we're promoting self-roster, so that we've got a number of areas that have started that already, where the team decide between them when they work, what shifts they do, and as long as that fills the roster, then nobody interferes with that. So we're rolling that out across the organisation, and we've seen some fantastic results in some of the smaller services with that. So we're doing that at the moment. But we've got some way to go to fill those vacancies nationally. The numbers of applications for children's nurses, adult nurses, midwives is down quite a lot. In Nottingham, we're quite lucky still that we have around 10 applicants for every place at Nottingham University. And they're really good candidates that come through. But there was more competition prior to that. So nurses in particular are being put off by what is happening at the moment. So that was all I was going to say. Councillor, thank you.
Thank you. Now, bear in mind the time. I'll come back to Councillor Welch.
It's really quick, don't we? Anthony, with not repeating ourselves, but just to go back to the starting point of when you came into NUH. So we're talking about bullying, we're talking about racism, we're talking about an inadequate CQC report, that no doubt the management or what has ever happened in NUH, what's happening there has affected hundreds, if not thousands of people. And this isn't something that's just happened yesterday. This has been going on for a considerable amount of time. Now, on page 26, on recommendation 3, number 5, one of the things that you say is about holding each other to account for behaviours, not just outcomes. Now, as you're going through this improvement plan and when you're looking at various incidents, how many of your own staff have you reported to the General Medical Council, and how many have you reported to the Nursing and Midwifery Council? Now, that can be the way you tell it is up to you. I'm asking for a transparent response, something that is meaningful to the people of this scrutiny committee, because I think it's very important, really, really important, because this for me will tell you that you are really serious about improvement, because there are things that have happened in your hospital that, quite frankly, should not have happened in your hospital. Not your hospital, our hospital, actually. It's everybody's hospital. So you can give me the data from your 100 days, or you can give me the data from the year. 100 days, I think, would be significant in the fact that it would be good to know that number, given certain things that are going on in the background. But there is no doubt in my mind there must be people, practitioners, that are working with them that have been needed to report for the GMC, that may have left the hospital already. That's a different discussion, perhaps for a different day, as to how that can happen. But how many so far have been reported, and what department do they lie within? Because I think that's a very, very important bit of information that the people of Nottingham should need to understand.
Yeah, okay, thank you. I don't know the answer to that. I haven't got that in front of me. We are doing a piece of work to make sure that our referrals.
In the time that I've been in post, I've referred one midwife to the NMC. One, yeah.
As for the GMC, our medical director is the responsible officer for referrals to the GMC. So what we'll do, Councillor Welsh, is we'll go away and we'll compile that data and we'll provide it to the chairman so she can provide it to the committee, but I don't have it in front of me today.
I do think that data is important, and I'm not pinpointing out you, Sharon. I just know that you know what's going on in midwifery. You're the brains and the knowledge. I find one concerning. I will not say that publicly. I find the fact that only one has been referred very concerning, and I find that, and I do think you need to get that data to this committee, because any other hospital that is failing, if you look at their data, they're quite clear of how many have been referred to the GMC.
Yeah, and we'll be clear as well. I just don't have it in front of me today, Michelle, so we'll very happily get that to you.
Thank you, Anthony. And finally, Councillor Fong.
Yeah, I think that data would be very interesting. I mean, from our point of view as well, because it's very difficult when you see a plan like this, good though it is, to actually say it's a bit like, so what, isn't it? If you don't understand actually what the action's been taken. And that's something I wanted to raise, especially from what Councillor Anderson said, because a bit of deja vu here, because this issue of constantly having to repeat and kind of the patient journey kind of not being respected in the way that you have to keep kind of repeating what's gone on historically over years and years and years. That is not, that again, it's not new, is it? I mean, I've got family examples I could give you, and certainly, since I've been a counsellor, there's an awful lot still around. So just a question out of interest. You did have a strategy set for your time, actually, 2018, didn't you, for a 10-year strategy? Have you abandoned that? I just wonder what status that is, because if there's stuff in that strategy that didn't work or was working really well, what lessons could you might have learned from that? Because it feels to me, from the kind of what you've got in here, you seem to be starting from scratch with some of the very basic stuff. And I just wonder if that 2018 strategy was working, and if so, what use has it been, really?
Thank you. So we're meeting next week, actually, colleagues at a senior level in the trust, senior executives and senior clinicians, to spend the morning making sure that the implementation of People First is aligned with the trust's previously published 10-year strategy. So I see People First as the halfway point, and our, if you like, trust-wide review of that 10-year strategy, because with a worldwide pandemic, all the things that we're seeing post the pandemic apparent in healthcare, not just in NUH but across the system, it did seem to me that we needed to review all aspects of what NUH does and not just rely on a strategy that had been written in very, very different times. But elements of that strategy and some of the roadmaps that go with it, we will retain in People First. In fact, if you look on the website and you look at our roadmaps for, let's say, our capital programs, tomorrow's NUH, our neonatal business case, the National Rehabilitation Centre, they're really easy to see and very straightforwardly laid out. I would not want to ditch that work because a lot of it is really, really good. It's a question of making sure that it's aligned in the context of People First, which is now our predominant strategy. So I kind of see it like a halfway point in that 10-year journey, and we won't lose any of the good work that's been done. But what I couldn't find when I came into post was an up-to-date roadmap for the future of the trust that did take into account the pandemic and all the other things that we see, which isn't to say that people weren't working on individual strategies in their services or even at a strategic level, but I couldn't see a single blueprint for the future of the trust that took into account recruitment and retention problems, flow through the hospital, the impact on planned care, the impact on specialist care. Now, we had lots of pieces of work underway to address those issues. What I wanted to see was all of them in the context of us setting three very clear priorities, which is to resolve those critical issues which are not unique to NUH, but to make sure we've publicly stated those other things that we're going to focus on in the future. Because one of the things that I talked about a lot in the 100-day period is the core purpose of the organisation. What do we exist for? What were we designed and commissioned to do? And if you take ED was not designed and commissioned for people to wait as long as they're waiting. If you take our planned pathways, they're designed to get people through as quickly as possible. Our specialist services are designed for people to get the treatment they need when they need it. Cancer services in that bracket as well. And what I wanted was to put all the good work that had been done in that 2018 strategy together into a refreshed sort of 2023 version of it, because we're halfway through. So that strategy was refreshed every year, and you can see that comes to board. So it's not that there wasn't a forward plan, there was. It was that strategy updated on an annual basis, and the people that do the work have worked with me on People First to make sure that it is all well. It's that, in my opinion, it was due a fundamental refresh because of the pandemic and all the various strains on the health service, and equally because we're now in a statutory integrated care system. In 2018, well, you could be a member or not. Now you've got no choice, and I see that as a good thing. We've got to work in partnership with colleagues. So I wanted to set it in that context. There's also something for me, Kate, about making the organisation resilient for the future. You'll have noticed that there might be a general election in the next couple of years. There are some local elections now. You might have noticed that as well. So equally, I wanted the organisation to pay a bit more attention to its surroundings, because like many big institutions, NUH can sometimes be a bit insular, particularly when, as Michelle has said a number of times, you're labouring under intervention and inadequacies. So this was also my way of saying, let's get out into the big wide world. That's why I'm here today, and be a bit more transparent about what we're doing.
Okay, thank you. Right, in the recommendation, we're asked to consider and comment on the information provided. I think we've well and truly done that. And I'm going to ask Anthony when he would like to return to update us on some more days and 100, 150 or whatever, however many days from now, when you'd like to come back, Anthony. And in the meantime, if anybody has anything that they'd like to raise with you when you come back next time, I'm happy for them to let Noel know so that he can give you advance warning of what people would like to know. But you've clearly had a very busy 100 days. You've clearly still got a lot of work to do, because Rome wasn't built in a day, but you genuinely are making improvements. That's very clear to see. So thank you for your report. Can you tell us some idea of when you'd like to come back to us? 6 months.
I'm on my way here, so I'll come back as often as you like.
Yeah. Okay. Thank you, Anthony. That's that's very kind, and you'll always receive a warm welcome, I'm sure. Now we'll move on to agenda item number 5, which is the maternity issue, the current performance and ongoing improvement work. Now, obviously, members will be aware that the Ockenden review is ongoing, and we as a committee had previously agreed to step back whilst the review ran its course. So what we're going to look at today and what we're going to be interested in is not what has happened before, that is being dealt with in the review. We're basically looking at what has happened since Anthony went to NUH, just so that members know they won't be asking questions, answering questions of what went before. Yes, Councillor
It's
Welch.
just a point of clarification in the report, just so we are completely clear and factually correct. It says that the report would help, the CQC report would help inform the national review. That's incorrect. The CQC report stands completely separate to the national review that is taking place by Donna Ockenden. The only way that they are connected is that the CQC has endorsed Donna Ockenden's review, but it is completely separate, and that is very, very important that that is changed because it is factually incorrect.
Have we got a note of that?
And legally, they sit very differently because it would be seen as CQC being involved in an independent review into maternity services. So it's not that it informs it. She's dealing with the cases as case by case that are coming forward. The cases will form the review and the outcomes of the review, not the CQC report.
Have we got a note of that, officers?
Yeah.
Please. Yeah. Right, so moving on from there, I'm mindful of the time, so one of you are going to update us on this. Anthony.
I will start and then I'll hand over to Sharon, who will take colleagues through the detail. Thank you for that point of clarification. I agree that's very important. So first of all, there's some context here, and Michelle started painting that context. Whilst the Trust has had a maternity improvement programme for some time, the context of the improvement programme and the improvement programme in the context of the Donna Ockenden review cannot be underestimated. Now, we are engaged fully with Donna's review, and I made it clear when I took up post that that would be a policy of the Trust, and we meet Donna regularly. We're going to meet Donna every quarter, and Donna will feed back findings from the review so that we can incorporate and update our maternity improvement programme as we go along. So it's important that colleagues know that this is a dynamic piece of work. We're not waiting for Donna's findings because these improvements have been underway in the Trust for some time, which is of course in itself a reflection of the 2 inadequate judgments that we've had in these services. There is a very strong and senior commitment in the Trust to resolve the inadequacies, and I'm sure we'll hear a lot from Sharon and Michelle, and colleagues will have lots of questions, I'm sure, about what that means on the ground and how effective we're being in those improvements. And we have taken measures to improve the leadership of maternity services and the way it's scrutinised within the Trust. Sharon will talk about the work that we've done, recruitment and retention, not just of midwives, but also leaders in the service, particularly to deal with things like culture and the way that we communicate and the way that we deal with families. But at a board level, we've also got what we call a maternity oversight committee, which is chaired by one of our non-executive directors, so a bit like an elected member. That's a lay person whose job it is to hold us to account on the improvements. And we're also We also report back regularly through that committee to the Trust Board to improve the sense of transparency and accountability, which is what I know colleagues want to see. And our Trust Board is like your council meetings. The public can come along and the media come along and report regularly on the work that we're doing. So first of all, we want to work with Donna because we know that's extremely important for the families and for the future of the trust, because we want to rebuild trust in these services. Absolutely critical that we do that. Secondly, there's a very senior level commitment to making this work, and we've got a governance arrangement in place so it's appropriately scrutinised in an independent and transparent way in public. And thirdly, we've got our maternity improvement programme, which is a dynamic piece of work designed to keep up with Donna's review, but also to fix stuff that was identified through the CQC inspections, but also in other reports that are in the public domain around maternity, such as the Morecambe Bay report, the East Kent report. Hopefully all of that is incorporated in to this approach. So with that introduction, Chair, I'll pass it on to Sharon, if I may.
All right. Thank you, Sharon. Over to you.
Thank you. Thank you for inviting me, and thank you, Anthony, for setting the scene there. So I just want to take you through the maternity improvement programme progress to date. So we've listed a lot of those improvements, and it's fair to say it is a significant programme that we have implemented, and those changes, and again some of the evidence of the impact that has had on our women and families, and how we audit and to provide assurance around those things. So, for example, around our risk assessments at booking, I can confidently say it's 100%. For example, we've implemented jaundice meters in the community, which identifies babies that need extra treatments and referral back into the hospital, which is an improved pathway, for example. So there's a significant number of improvements that we've made over the last 2 to 3 years as a service, but that is notwithstanding the continued journey that we are on and the significant size of the projects that we have underway. And given that it is a significant programme, we have committed to do it in bite-sized chunks. My analogy that I use, I think I'm going to get a t-shirt printed. It's like having a buffet with 300 things, separate items on it, and being expected to eat it all at once. That is an impossible task. So as a service and with support from Trust Board and Anthony, we've narrowed that down into 4 priorities that we will do at pace, and that is an ongoing thing that we are looking at by the end of March, that we will have implemented some of these things. So the broad headlines are around governance, communication, engagement, pathways, specifically around postnatal care and the implementation of badging. And I was interested to hear some of those comments about the wider service and that end-to-end system and how we communicate, because we've actually implemented that in maternity. So I'll come on to that in a little while. But we are doing this through a quality improvement methodology. So that means that actually it may take a little bit more time, but we know that then it's a sustained improvement rather than something that we've just done very quickly without having a robust framework to be able to review, go back and make those amendments. So we've had support from the Trust around embedding a quality improvement methodology, which I think is something that's really, really positive. And alongside those 4 priorities, we have enabling work streams as well, such as the staffing and culture and leadership, which of course will continue as the key themes and threads through all of the work that we do. So if I just take you through very briefly some of those improvements. So the governance one, we've looked at the framework. Again, we've had additional staff come into the Trust and an opportunity to review our processes, especially given with our serious incidents that we have a really robust, sustained process for that, and a really clear pathway for not just doing the reviews, which is really important, but how we learn the lessons and embedding evidence that we have embedded those lessons into practice. We've reviewed our risk management process and our guidelines as well. So that's an ongoing piece of work that our team are doing, certainly with that focus on the processes, the SIs, and general risk management there. communications were really clear that this is something that we've probably not got right in the past, and we need to improve both for our staff and for our families as well. So with the support of the communications team, we have a dedicated individual who supports maternity for communications. So we've got a roadmap. It's not quite ready to share, but we certainly will do, which will be publicly displayed to show how we've made those improvements across the board, and that continued improvement that we make to be able to show that to our family, that we have families, and to also for our staff as well, because we've made so many improvements. Again, we know that we've just done a survey on staff's awareness of the MIP, and although that's high, I think there's some more work that we can do to be able to identify. So some of the things I've talked about, the jaundice meter, I think if we ask a community midwife, was that part of the maternity improvement, they might say no. They understand that actually it's a safety improvement and the benefits of that, but can they relate that specifically to the maternity improvement programme? And that's the work that we're doing. We continue our engagement with women. We have a really good relationship with the MVP, for example, and the MVP, so the Maternity Voices Partnership. I am sorry for using acronyms. So this is a part of the ICB and the local maternity neonatal system, and they provide a support and a service user voice in maternity services across the system. And so our chair Amanda is very active and supportive, and she attends our workstream meeting. She's on our engagement and inclusion, and she has come to the maternity oversight committee recently and will continue to be a regular member of that team. In addition, I have engagement events. We've got one on Thursday with staff, and we have I do a monthly update on Facebook for questions that are coming from women and families that I answer specifically, and we're hoping to do an open session, a question and answer session with myself and the MVP chair in the next couple of months. That will be something that is done live. We are continually monitoring our friends and family, and I can report in the last couple of weeks it's actually been around 96% that have a very positive view of maternity services. And coming back to Badgernet, which is a really key theme, we have women can access friends and family now on the Badgernet app that they can download on their mobile devices or iPads, etc. And that we've also included the maternity national survey, the PICA survey, which is something that trusts engage with, which is a CQC event, and our responses have formed the direction for travel in terms of our postnatal pathways. So we are specifically looking at postnatal care because we've had feedback from women through friends and family, complaints and other comments, but also from our staff. And we know also that it is an area where we need to focus in terms of the flow for women and babies going through the service as well. So it is complex in terms of at least 6 elements to the postnatal pathway. So for example, we're looking at the newborn examination and how we have a more robust process to ensure that babies are checked as per the national screening programme before they leave the hospital, and we're looking at our elective caesarean pathway for enhanced care so that women can leave the hospital within sort of 36 hours. Related to that is our medicines to go home and prescriptions, and so there's lots of elements that we're working on in terms of improving that pathway. So that's incorporating the voice of the women and the families, but also our staff, and they are leading a lot of those improvements through our shared governance councils. We have a midwife who leads on this specific safer care element of the maternity improvement programme. So our digital is a real success story. So we've implemented Badgernet, which is an end-to-end maternity clinical electronic system. So we have very little paper in maternity now. And this has been across the system, so across the ICB, so our partners with Sherwood Forest to implement that, and it has been a real success. We went live with it in November. We did it in a staged approach, so initially it was community antenatal care, and then the whole lot was on the 29th of November. I think it's embedded, tattooed somewhere of me, that we went fully live with that. And we know already in December that we had 66 women women, I think, that came from Sherwood Forest to Nottingham, where we could just see instantly their records. So again, coming back to counsellors' experiences, it's there instantly and we can share that information with all Badgernet trusts across the country if women come from other areas. So that has been a real success for us. Our staff, we've done a survey on staff and how they found Badgernet, again very positive, especially in community, which is where the vast majority of care is provided. They're seeing that benefit in the not duplicating, having to print and send paper copies of things out with the work that they're doing, and that means they're released to spend more time with women, which is really, really important. And women can access their records. They can, when they book with us, then they're given a password to access Badgernet. It's an app that they can download. They can see their medical records. So everything that we put in there is there for them to see. They can access information, advice. It's all there in one place. And Badgernet are rolling that out in terms of different languages by the end of March, that it will be available in 10 different languages. But whatever your Google setting is, it will translate as well, so that information. So we are reaching out to our non-English speaking women as well. So that's a real positive. And for me, I probably am the bane of my staff's life, because I can look at Badgernet and see who's in, what's happening, and so I keep a very close eye on some of them. So that's a benefit, and that information that we can get out of it. So it has worked really well. It's a brand new system. We're still learning. We're still to learn the maximum benefit for us. But in terms of those initial couple of months, it's been really, really positive. I've touched on the CQC Picker survey around our postnatal care. The three things that came out for us that we scored worse than other trusts was around partners being involved or being able to stay, but we were working within COVID times. But that, I'm happy to say that from September last year, partners can stay 24 hours a day. There is no restrictions. We've pretty much opened up as pre-COVID, which is really positive, and around support for feeding. And that is not just a maternity, that's actually out with our partners as well in primary care and other infant feeding groups to support women too. But we have invested more in our infant feeding team, which is positive. Just to touch on workforce and staffing, because that is our biggest compounding factor, and absolutely essential that we get that right. We've just undertaken a Birth Rate Plus workforce review, which is a national tool for midwifery staffing, and we've had that report back, and it's given us recommendations of where what our vacancy or what our gaps is. I'm currently working on a paper with the team, and again supported by the board, to over-establish. We know nationally there is a shortage of midwives, and we're all fishing in a very small pool with our neighbours at Sherwood Forest and Derby and Leicester, for example. So how we attract and keep our staff is really important. We've had a really successful campaign as part of the project with the regional team. We've gone out to South Africa and we've recruited 18 midwives that will be coming to us from May onwards. It's really exciting that we've had this opportunity. Included in that 18 are two male midwives, which again I think is absolutely fantastic. So the important part for us is to be prepared to support and welcome them into the service, and if there's South African community can help us with that, then that would be absolutely fantastic. So it's really important that we get that right. We've also recruited 3 substantive consultants that have started in January, and we have about 2 whole-time equivalent gaps which are currently going through college approval to go out to adverts. So that will mean that we are fully established with our consultant body. So that work around the recruitment retention continues, and as Michelle said, flexible working is really important to us, and we do offer that. It has to be within the context of what is appropriate, or what we can offer for that individual. So we will support people's flexible working, but if they work in a very small team, it may mean that they have to, we look at where they can work in another part of the service, but we have to make sure that we're staffed safely. The gaps that we have in our service currently, we fill with either NHSP or bank staff or agency staff as well. So we look regularly we have a every day at 9:30, including Saturdays and Sundays, we have an MDT or a multidisciplinary team cross-site meeting, which tells us what our staffing is like, what are our issues and challenges, so that we can provide cross-site support and oversight. And that includes anaesthetists, our obstetricians and neonatal services too. So just to round up around the independent review, we are absolutely committed to making the changes from and learning from where we haven't got it right in the past, and we are fully and openly engaged in that process with Donna Rockenden and team. So I feel it's hopefully a positive relationship, but it's absolutely transparent and as open as we can be, because it's really important that we get things right for our women and families going forward and learn those lessons. So I will stop there because I'm sure there's lots.
Thank you, Sharon. Just one thing I'd like to ask. When I first, did you want to speak?
No, it's fine.
I didn't want to miss you out. When I first started to chair this committee, what is nearly 2 years ago, those of us who were on this committee in the beginning will remember that we had some horrific figures of incidents, and we couldn't at the time clarify what kind of incident. It took us a long time to find out the segregation of incidents. Now, on here, you've reduced from 61 to 29, but during which period are we talking about? A month, 2 months, 3 months? What kind of time? And basically, how often do you report these?
Thank you. So it isn't, we call it a backlog, it's not really a backlog, but those 20, now we're down to 29 cases. The latest one we have is from May last year up until September the 14th this year. So those cases are being in process, being reviewed, so that we have a report. We have a process where we take those reports and action plans to our to the LMNS, the local maternity neonatal system, for oversight and comment and for learning across the whole system. So we're confident we'll get those 29 done by the end of March, so that we can get the reports to families and also those lessons learned. You've asked for the figures from June 22, and we've had 23 serious incidents declared. I'd like to say that we are a positive outlier, and NHS England have commended us for that, so that when we have an incident, we look at it as harm as experienced rather than harm as caused. So that is a positive. So we will always have more serious incidents, because we come from the view of the experience for the woman and the family, rather than if we have contributed or impacted on that care directly. So we have a slightly different approach to serious incidents than other trusts do. And I know that from other trusts, when we had those conversations, that we take that approach, which is absolutely the right one to take.
So just going back on this 1 second before I hand over to members. 23. Are these 23? Well, what did we have? We had brain damaged children. We had deaths, stillborn. What are they?
So in the 23, there will be what we call maternity triggers. So, for example, a massive postpartum hemorrhage, for example, or a woman being admitted to intensive care because that is an experience, that's an unexpected outcome. It doesn't necessarily mean that we've contributed to that because we review it. With the numbers for the neonatal deaths and stillbirths are very low, so I don't particularly want to share because I think it might be identifiable. But in that time, we've had no maternal deaths from June 23.
Okay.
22, I'm so
22.
sorry. So, and there are criteria that maternity that meet for declaring serious incidents. So there's a whole range. So they say unexpected admissions to neonatal unit, for example, or if there's been a communication issue or something like that.
Okay, so there is some improvement there, which is what I was interested in. Members, anybody want to comment on this? Councillor Welsh.
Thank you for giving us the update, and thank you for being involved and working with the Donna Rockenden review. That does make a huge difference, and it is quite refreshing to have that kind of support for the families. Well, I don't claim to be an absolute voice for every single family in Nottinghamshire. If I could just bring it down a level to the human aspect with regards to this, what's happened and what's happened with it has devastated lives. Utterly, utterly devastated lives on so many different levels. It's changed me. I am the shadow of the person that I used to be because of what has happened to me. Not what has just happened to me personally, but the fact that I work with these families and see it every day. And the reason I want to bring it down to this level, because I think it's really, really important that when we're talking about the improvements in maternity services, that we remember this is about women and babies and not necessarily about all the data that surrounds it, although that is very important. So you actually being involved and supporting the Donna Ockenden review makes a huge difference. And Anthony, the fact that you have been meeting families makes a huge difference, because the biggest battle for families has been the fact that they've had to stand up in courts of law, they've had to stand up in front of the media, and they've had to retell their stories because NUH wasn't listening, including myself. And that's the bit that's done me. The fact that I have to keep going over and over and over again what happened to me. So I just want to get that to that human level, and I know that people are working within the maternity departments to make those changes. I do. I get it. I understand that, and I do believe that you are working hard to make those improvements. But I have got some questions. So we've just talked a little bit about the serious incidents. It was recently reported about the 41 serious incidents that had gone past the 60-day mark for investigation, which is what is statutory required. You've also been issued with a record fine of 800k, which the judge did say, barrister did say, that if you weren't a public organisation, that fine would be far greater. And once again, the Andrews family had to stand up in a court of law and talk about what can only be described as an utterly horrendous situation. Don Rockinton's been in to talk to you about how you communicate with families already as part of the review. So my question is, we've still got serious incidents. Councillor Sue Sannington has asked the questions with regards to whether they're being reduced or not. That's great that they're being reduced. I'm still unsure as to what those serious incidents are by each one. I want to know when it's going to get to the point where we're not 60-day past what is going on. But I'm going to go back to the fact is, this isn't something that happened overnight. Okay? This crisis in the maternity departments didn't happen in a week, didn't happen in 6 months. It started years and years and years ago. And your own staff, your own midwives, the NUH, sent a letter to the board, some of them that are still in place now, Anthony May, in you, and that letter was fundamentally ignored. And they were saying that the safety of mother and babies at NUH is fundamentally at risk. That's reality. Well, that's not going back to the CQC report. That is fundamentally what happened. You apologised to the families at the beginning, and the families appreciate that. I appreciate that. But we don't want sorries. We want action. At what point does NUH take a stand back and say there needs to be some accountability here? Because it has gone on for years and years and years and years. And by going on for years and years, mothers have died. Babies have died. Babies have been starved of oxygen that shouldn't have been starved of oxygen. Women have left NUH totally traumatised that don't even meet the criteria necessarily for Don Rockinton's review. But they've had such a poor experience in the midwifery department at NUH that they are totally traumatised, and it changes you for life. And a part of the group that I'm on, you wouldn't believe the amount of women that come forward. 2016, 2013, 2012, 2010, 2011, all the way up until present day. And this may not seem like a question, but it is a question because I want to see accountability. I want to know why this has gone on for so long, who is responsible for allowing it to go on for so long, and when is someone in NUH going to stand up and say, not only are
Councillor
we
Welsh,
improving
I think
this,
the
no,
report will, no, just one moment. I think the Donna Ockenden report will look at what went on before. We're actually
no.
discussing
So I want
today.
to know when Anthony, that we will see some accountability with regards to this. And then my other point goes back to in March 2022 when we had the previous, you were here, you provided a maternity services report, which was a monthly report that provided the data I think this Health Scrutiny Committee should have seen on this occasion, which goes into detail with regards to how many stillbirths, etc., etc. That's the kind of data that we should have been seeing today, and I'm disappointed that it's not here.
Anthony, I realise questions have been asked before your time, but in actual fact, the idea was to discuss since your time. So it is up to you how you answer this question, because the review will clearly be looking at things that have been mentioned today.
So, thank you. I'm happy to try and answer Michelle's questions. I think that they are perfectly reasonable, and of course, it's difficult for me to speak for the time when I wasn't accountable at NUH. But there is a strong sense of accountability, Michelle, amongst board members, and of course, in an NHS setting, board members mean executive colleagues as well as non-executive colleagues. The chairman of the board is new, and along with me, has been brought in to make sure that we first of all are transparent and apologetic and sincere in that, and secondly that we put some action to that, hence me meeting with the families and engaging in the way that I am today in open debate about how we can put it right. It's more difficult for us I think, to go back in time because we weren't there, but Donna will go back in time. The scope of Donna's review is very clear, and to support Donna's review, I'm doing everything I can in the trust to understand, particularly where there may have been significant events, CQC reports, inquests, whatever that might have looked like, to make sure that we learnt the lessons and took the necessary action. And that's a piece of work that will take me some time, and as yet it's not complete, but we are looking at whether there were significant missed opportunities so that we don't wait for Donna to tell us, because we think we ought to be working hand in glove with Donna so that if there are things that we should and could have done, we can learn the lessons now and make sure that we put all of that into our improvement plan going forwards. So you have known me for a long time. I'm not going to obfuscate around this issue. If there are things that I find that we should or could have done, I'll take the appropriate action. But looking at these things retrospectively, you know from the work that we did here with ICSA, is extremely difficult and often very traumatic, particularly for the families concerned. So I'm equally sensitive to the families involved in this, and the families that I've been met. I feel that I've been privileged to listen to them, and where things have needed following up, I followed them up. But there's a limit to what I can do looking in the rear view mirror. There have been changes at the Trust since the reports were published, and I'm sure there will continue to be changes going forward. And Donna has been good enough to say that she'll meet us every quarter to feed that learning in. I'm personally in regular contact with very senior colleagues in NHS England to make sure that we are working properly with Donna and we are transparent and open about these matters. As far as serious incidents are concerned, if and data, if you would find it helpful to have more data when we come along to these meetings in future, if you'd be good enough to work with Noel and the chairman, request data that you think will be helpful. Believe you me, we'll have it. We're a data factory. We'll get it to you and present it in a way which is helpful and enables you to scrutinise us. We really don't want to hide anything that's happening. As far as serious incidents are concerned, there are a number of criterion that make up the criteria for serious incidents. Colleagues can describe those for us, and then if you want to understand how the backlog of serious incidents, as I describe it, fits to that criteria, 60 odd, we can do that, and then we can give you a high-level analysis of the new ones, because they come along all the time in a big trust, fit against that criteria, provided we don't get too granular, because it is possible to identify individuals against that if the criteria is very narrow. But we don't want to hide any of that either. So with that said, Chairman, if I could ask either Michelle or Sharon to talk us through the criterion that make up the serious incident criteria, and then if you would like further data on that following the meeting, we can get that for you.
I mean, it would take some time to talk through all the criteria. So I wonder if it's best if we, I mean, I'm really happy to send the criteria so you can see that, Chairman. I'm just thinking of the time of it. But it's difficult. I mean, I wouldn't go into the 23 and what they are now, even though we probably could between us, because Sharon and I are, you know, all over this for maternity. Some of that information will mean that families may be identifiable, so it wouldn't be the right thing to share that here now. We wouldn't do that. If you just want to mention the HSIB.
Yes, so there is an external investigation process for a criteria of serious incidents of maternity. So those are maternal deaths, neonatal deaths within 7 days, intrapartum stillbirth, so babies are over 37 weeks, and babies that are admitted to the neonatal unit for therapeutic cooling. So that's to do with those brain damages and hypoxic events. The last two HSIB reports that we've received recently had no safety recommendations or actions. So, you know, notwithstanding obviously the trauma and the impact of the family, the loss that's happened, actually when it's been reviewed externally by experts, that there were no safety concerns at all for NUH to action.
Thank you very much, Chairman. My point is looking through the maternity improvement report that you've given us, and thank you for that. It's really helpful. I'm from Healthwatch, for those who don't know me. So Healthwatch is the sort of watchdog, I guess, and we're very much involved in understanding how patient experience plays out across our health and social care services. So when I'm reading this report around communication particularly, and looking at the involvement of patients, mothers, carers, families, I suppose I just want to sort of understand a bit more, because it seems not very in depth in terms of what I see here. So whilst there's conversation about providing lots of information about what's happening with improvement, which I absolutely welcome, I'm interested in how you're actually involving patients and people that have been through your services in how you are improving those services, because there's a lot of information about how you're listening to staff, quite rightly, but I'm not really seeing how the patient experience is actually being integrated into the improvement plan. So I'd like some more information on that. Thank you.
Thank you. So, I mean, it's absolutely essential that we have that user's voice through everything. We are really engaged in that co-production work. So from the very start, and it comes back down to our MVP, but also others. I have someone who I've met through her experience at NUH who is actively engaged with us. She's not part of the MVP, but she will go and talk to women on the wards, feedback to us. She'll do specific bits of work, and we're expanding that. I know that Anthony's met a family recently who I'm going to contact again to be that service user voice to give that representative a view, that viewpoint on everything that we do. We're interviewing for a matron for engagement and inclusion. So again, with that specific remit for service user voices and making sure that we capture it as much as we can. We have the statutory friends and family, and we receive lots of compliments as well as complaints as well, which we absolutely take on board and respond to. So we are taking that active view. Is it enough? I think there's lots more that we can do. I'm going to a trust that I know has just recently been rated good in terms of their CQC, and a key part of that was about their family engagement. So I'm going off to there to go and say, well, what are you doing differently that we can learn from, and having that outward view. And we also did a Whose Shoes event. So this is a workshop. We did it with the support of the LMNS. System-wide, we had service users, different stakeholders around our home birth services. We're also going to repeat that in the next few months around our BME population, again from the perspective of our BME staff, but also women who engage in the service. So there's lots of work that are ongoing. So I apologise if it wasn't as strong as it could be in this report.
That much of our engagement is done through the LMNS, which Sharon referenced, which is the local maternity and neonatal system. It's a board which I chair, which we have across our whole system. And we have through there the Maternity Voices partnership that Sharon talked about, and really engaged people. And that's been redesigned very much to bring people into that strategic leadership space, that policy setting space, that sort of how do they feed into improvement plans and transformation rather than reactively when experience has been poor. And as part of that, we've just appointed an independent senior advocate who will sit in the LMNS and report independently to the chair directly, but have scope to work with all of our services to escalate any issues or concerns, or support women and birthing people to raise their issues when they're in situations they don't feel they can, or that trusts aren't listening. And we know there is more to do around that MVP in terms of both it being inclusive and representative. And we've committed as an LMNS to a year-long project to work with the MVP and all our partners to grow that into a really strong voice for women, families and birthing people in Nottinghamshire. So there is more happening in that system space that supports the work that Sharon is doing within the Trust.
Thank you, Rosa. Did you want to ask?
Just to come back on a point that was made, and I welcome that it was made, was around doing one of the next workshops around Black, Asian, minority, ethnic patients, families, staff, because that relates to a point in Anthony's 100 days around culture. And just obviously, I was privileged to be at the event last week when Anthony was at City Scrutiny, and that was a really important thing I think came out, which was the impact of the issues around culture that NUH experiences, around, particularly around racism, quite rightly called out in that way, Anthony, and how that it directly impacts on patients. So I just wondered if you wanted to sort of say something about that, because obviously some of the main issues that were, some of the issues around maternity did relate to some of that difference. Things like black women not being given the same pain relief, around racist attitudes towards women and how people are treated differently. So I just wondered if you wanted to comment on that and give us some feedback of the intersection of the work that you're doing around racism and bullying and maternity.
So one of the things we're doing to better understand and listen to our women, particularly from black and ethnic minorities. Anthony mentioned earlier, as part of the team, we appointed a assistant director of nursing for inclusion, and as part of her team, she's appointed a matron who is working with the community services. So on you, who you would have seen last week, and Lovelin are doing quite a lot of work now with local communities, getting out there to talk to them and encourage them, not only around maternity, I have to say, but much wider than that. And we'd be really happy to talk to you about that. They're doing lots in community centres, talking about screening and all kinds of different things. They've both been, I mean, the assistant director has been in post for probably 6 months now. The at Lovelin, the community matron, has only been in post for 3 months, but that is the start of it, and it fits into exactly as Anthony has described in the work that we need to do. So it is a really big part of, and she's linking with the maternity teams to look at that. So that is happening at the moment. And of course, I'm sure you will have seen on the news that Mrs. Ockenden and her team are doing lots of work out there as well, talking to ethnic minority women and getting right into the community to understand their thoughts, and so that we get that back as well.
Thank you, Michelle. Councillor Butler.
Thank you, Madam Chairman. Well, at the heart of what you do and what we do is the patient, both the mother and, of course, the babies as well. We never get away from that, never lose that fact. Now, Sharon, you gave us a very comprehensive introduction as to what's been going on, and quite rightly so. And I may have missed this, but I've just one little question I've got under your progress to date paragraphs, and I'm just interested to find out more. And this is the introduction of the maternity advice line that you refer to, which sounds very, very positive and helpful. How's it going? I mean, is it what sort of patronage usage are you getting? Is it well promoted? Can people keep going to it whenever they want to? That sort of thing. And I hate to bring in sort of things like targets and things, but do you sort of target that sort of thing? Are you expecting to get a certain number of calls or certain types of calls? But importantly as well, if you've got a mother or anyone phoning up, during the course of the discussion they have with the midwife, and I'm really interested or pleased to see you've got this 24 hours a day. Should something be said during that conversation that starts, for want of a better expression, ringing alarm bells? Is there a method or a system in place that whoever is on the call can be referred to wherever they might need to be referred to, for example? Just how it works, really. That's all I'm thinking.
Thank you. So this is something that a lot of trusts don't have, and has been really successful. We went live with the maternity advice line in October 21. It's staffed 24 hours a day with midwives. So there's a minimum of 2 midwives, usually 3, between 8 and 4, 8 till 8. And then overnight, there's at least 1 midwife on the advice line. We take over 1,000 calls per week. And we monitor our response rate so that we can make sure that, for times of peak activity, that we've got staff all. It helps us with our workforce planning and how we can make sure that we answer more calls responsively. For women who, if there is a delay in answering the phone, there is a message that says if you think you are in labour, you can ring directly to the labour suites. It is the number is given to every woman that books, and it is how women engage with the service, and it's in response to, as most trusts do, they have to ring individual departments, and if staff are busy, they don't answer the phone. Community midwives, as I said before, is where the majority of care and maternity is provided. But if they have a mobile phone, if they're off sick or absent or on holiday, then it is not a robust system for that woman to be able to make contact with the service. So that's why this is a really important service for us. We did a review, or we asked for women's reflections on the maternity advice line, probably about this time last year, and it was 100. I know people can't believe, but it was 100% positive. So women that have had babies before and had not had this service and have engaged with when we've had the maternity advice line, or for those that have never had it, then there was the comments were completely positive, which is really, really good. So it's now we've got Badgernet again. You can see the whole pathway really easily. So it's it's a really great service that we offer to our women, and we will continue to do that. And yes, in answer to your question, they will. It enables us to manage our flow through maternity. So if we know that there's some maybe pressures on one site, we will say, actually, can you go to the sister site for your care, so we can direct women appropriately, so we can manage waiting times, we can manage our activity across both units really safely, and they can alert to anybody else that they need to, and refer on to those other departments as necessary. So yes, it is a really good service that we offer there.
One other quick question is it, and this might be my ignorance, so apologies if it is, but is it a free call or just a or is it?
Do you know? I don't know. That's
good question.
Michelle knows it. I don't know.
It's not free, but it's probably just a local type call. Oh, fine.
Yes,
So
it's a Nottingham.
So the main thing is it's not anything silly like an extra cost premium call
it's
or
not
anything silly
no,
like
it's not
that.
a free phone.
No.
Thank you. Councillor Fold.
carried away. Getting carried away now, Chair. Sorry. Thank you. I think I go back to that comment that we talked about earlier about not being kind under pressure, Anthony. I mean, the idea that black women were given less pain relief, I found that quite sickening. That's appalling, isn't it? I just can't really quite get my head around that. And surely that would be a serious disciplinary matter. I'd like to know how you're holding people to account for that. I think that's just absolutely unacceptable on so many different levels. So, number of questions. I mean, and in here, which is clearly kind of that kind of an operational kind of thing of kinds of things you want to do. Again, I want to come back to the cultural issue that I think you raised earlier. So, how are you holding people to account for that kind of appalling behaviour now? And I know Michelle raised it earlier, and I'm still not quite sure how you are holding people to account. I'd like a little bit more detail on that one, please. And again, it's great you're having matron for inclusion, and you're sitting on some new posts, which is great. But just a small number of posts isn't going to do it, is it? This has got to be in the DNA of the organisation. This has got to be absolutely unacceptable behaviour right the way through the organisation. And I don't see how you're going to be able to do that quickly enough by just appointing some new people. Important though that might be.
Thank you. Colleagues might want to describe the processes we use to manage performance.
Yes, so there are different processes. So if there's an incident, then we review and we look at the individual. First of all, we speak to the individuals and they will do an account of their care. We will look at it, whether it matches guidelines. People work within really complex systems and processes, first of all, and we have to take the view, and we do take the view, that people come to do a good job every single day, but sometimes it doesn't go as they planned. So my job really is to make sure the systems and processes are there and enable them to do the best job that they can do. But sometimes people do make errors. So our first approach when we've looked at that is to support individuals in terms of their learning, their competencies. We put people onto, it used to be called supported practice, but onto action plans to address those issues in their care, in their performance when that has been lacking. And we have a very robust process supported through HR to do that. And we also have professional midwifery advocates which support individual midwives in their practice. And midwives can refer themselves to the PMA, the advocate role, if they want additional support for an element of their practice to support. So there's that element. And then, of course, there is the disciplinary policy for actions that are not the ones that we would expect any of our employees to undertake, and we follow that very, very robustly. So it's around accountability. It's whether we're just talking about those incidents, clinical incidents, where we've reviewed care and things haven't gone as they should have done, and the individual's reflections, how we support them in terms of additional training, setting a very clear timeline on that. So, and there will be a point for some people that we actually say, this is untenable. We've tried. We've attempted, and it is no longer, safe for you to practice. And we've put positive measures in for that. Or those where it's in clear breach of our guidelines, our policies around disciplinary matters, such very serious incidents from a contractual standpoint. Does that? So we do that because actually, my stand as the director of midwifery is: would I want this person to look after my family or friends? And if I say no, I wouldn't, then we absolutely do something with that individual.
Cover briefly. What I want to hear from you is that you are tackling racism, bullying, absolutely, and that's and coming back again to the issue earlier about only one midwife is being referred when there is what I understand to be the case is there racism, bullying is part of the culture. Those two things aren't really adding up for me at the moment.
I would need more information on that because that isn't. I've met with staff and I do have those conversations with individuals where there are concerns about their behaviour. When you come back to the culture, it's how we present ourselves as leaders and the expectations of how others behave and holding them to account. And we absolutely do have those conversations with individuals, again with related actions for improvement and continue checking in with their colleagues if those matters that continue. So we absolutely do address those issues.
Thank you. Anthony, you wanted to just pop in there with something?
I was only going to say that if you have got specific information that you want to share with us about colleagues from maternity in particular that have experienced those issues, I'd be grateful to see that. This is not just about midwifery. So as the chief nurse, I've responsibility for nursing and midwifery, and I'm very clear, as is Anthony, that it is a red line. So it is something that we and I have had nurses come to see me. I haven't had any midwives that have come to talk to me, but I have had nurses, one of them being Anya, who was at the Health Scrutiny Committee last week, and Anya and I are in a reverse mentorship relationship, so we reverse mentor each other. So I learn, walk in her shoes as she does in mine. So I have had nurses that have come to talk to me to say they are being people are being racist towards them, and we have taken that really seriously. I haven't had that from midwifery, but it is something that is an absolute red line to us. That's one of the reasons that we appointed Assistant Director of Nursing for inclusion, so she could help support us and guide us through. Because I'm a white middle class woman who hasn't walked in that shoe, but certainly Aqualine, Lovely, and Anya, and some of the others have, and we do take that really seriously. But if you have got information, please share it with us because we'd want to do something about it. Okay. Thank you.
All right. Did you want to come in?
There is another aspect of this, Chair, which I should say, because it was an important part of the Winter Andrews case that Michelle referred to earlier, that the judge in that case was clear that the penalty was against the trust, in that in many ways the trust failed the staff as well as failing the Andrews family and baby Winter. And we have made improvements, for example, in the way that colleagues can access advice and guidance. There's reference to it in the report. We call it the Pocket Pal app in maternity, because what the CQC found, and colleagues that looked into the tragic death of Winter Andrews, supported by their evidence in court, was that staff didn't understand and weren't complying with guidance at all times. So as well as the staff needing to be held to account for any individual failings, and we've heard from Sharon the process that we use for that, it's equally important that the trust provides staff with the appropriate support and guidance so that they're operating correctly and within their practice guidelines. And we've now done a lot to improve that, because it really is important that we support colleagues in these very difficult and sometimes lonely and vulnerable jobs. So I do believe we've made a lot of improvement in the way that we support our colleagues, as well as making sure that individuals to account if necessary.
Thank you, Vice Chairman.
Sorry, maybe jump. With regards to the two heads of midwifery that have been are in place now, how are they impacting the new day to day? And my second question is, with the newly qualified midwives, I know with nurses you get a preceptorship, don't you? And I think it's a 6 months preceptorship, or however long it is. I think it was 6 months. How does that impact on the wards as well? Because I know if you've got 10 new people, that's an awful lot of people to support as well. I just wanted to know how that works, really.
Thanks, Beth, and that's a really good question. So yes, I'm really pleased that we've appointed two heads of midwifery. They joined the trust in January, so it's early days yet, but I'm already starting to feel the benefits, and I know going forward it will. So I have a head of midwifery for workforce or operational to do the day-to-day stuff, because my role is strategic and I need to raise myself up, so I've been managing everything really, obviously with some support, and a QRS, quality risk and safety head of midwifery to address the governance arm as well. So I think it's a different approach rather than having site-specific heads of midwifery, because we've been out before in that model and it doesn't necessarily work. So I think it will strengthen that leadership, that visibility, and hopefully lift everybody up. So I think it's a real positive. In terms of preceptorship for a newly qualified midwife, it's 12 months, 12 to 18 months generally, and they have a robust programme. and we have support, we have mentors, so they have a buddy preceptor mentor, if you like, in practice. We have designated clinical educators for supporting newly qualified midwives. They have a supernumerary period of time when they go around each of the areas. So it's about, they are registered midwives, but it's about just consolidating their training so that they can be the best midwives they can be. So it works really well, and we've kept quite a lot of our newly qualified midwives. So it's a real positive. And for those that are either struggling, we will offer additional support for them, or if there's an area where they're not meeting their competencies, we will ensure that they go to that area to be able to do that at the pace so that they can then be accelerated into the banding for a registered midwife. So it's a really positive approach. Yes, and then onboarding for our overseas midwives when they come. Again, we've had successful projects in the nursing body in the trust. They're helping us with this because having 18 come from South Africa is a significant challenge for us, and we want to absolutely get it right. So they're not going to come at once, they'll come in stages so that it's manageable. So sharing the learning, but also having a dedicated person for those recruits and training is something that we're doing as well. We have got that person there doing that.
Councillor Adams.
Thank you, Chairman. Yes, I wanted to ask a question about the Badgernet system and its relation to, can it take compressed image files, can it take compressed video files, or is it specifically purely a text entry system? I have a follow-up for that.
No, it links to Viewpoint, our scanning system. So there are different. So Badgernet, our master system is Medway, so that's a one-way feed with the demographics into Badgernet. But we can certainly attach files and things like that into Badgernet. I wouldn't be confident to say that it will take video things, but we have a link into Viewpoint from Badgernet into Viewpoint, which is our scanning system, so that clinicians can see scans. We've had an update on that in the last month.
Thank you for that. And follow up. It struck me with the awful case that was raised a second ago by Sarah Health Watch. How did that get determined? How did something like that get determined that a pain relief issue had been tied into a racism issue? How do you now capture that information? How does it come from? Is it like you discuss it with the nurse, you discuss it with the patient, you discuss it with the colleagues of the nurse? How does that come about? As far as determining that now, because I understand we're not talking about then. So now, how would we determine from a case like that? Obviously, I would expect from a HR perspective, you should be going, direct to disciplinary, do not pass go if something like that's been proven. But what I suppose I'm trying to understand is there a better way to capture evidence? Is there other ways of capturing evidence? Have you looked at other ways of capturing evidence for the process of an interaction? Because I imagine a lot of the interactions that happen across NUH are one-on-one. There's probably not a lot of necessarily witnesses to events. And so a lot of this information that happens, things, interactions, people will say this happened. Maybe the clinician will say, well, that happened. And it's how do you determine that? Have you considered using any other mediums to capture that data? And if so, what are those? Because it just, because of that one-on-one interaction and because of perception, I think it'd be interesting to understand how you can determine that so that you're not only protecting the patient, but you're also protecting staff as well. That's it. Thanks.
Thank you. So there's been national work around the preconceived ideas. I think that case that Sarah mentioned is something that we can all reflect on through across the country. And there is a piece of work called 5 Times More, where we know that non-English speaking women, BME women, have 5 times more likely to have poor outcomes, stillbirths, etc. And we are working around cultural competency, so that is a piece of work that we're doing to reflect that. And it's bigger than NUH. It is a national piece of work that's happening, and to reflect our populations in everything that we do. For example, around our training, so having cultural, so ethnically diverse mannequins, for example, because how you identify ill health in a white woman is different to a black woman. And so we need to get, with all of our training, we reflect our population to ensure that we don't repeat these cultural norms, if you like, or the lens that we have as white middle class people, to reflect our population and demographic properly. So it is something that we're very aware of. It's a piece of work that we're really keen to do in terms of our SIs and some poor poor outcomes reflecting our ethnic diversity. So actually, are we seeing in Nottingham that 5 times more? Are those women more likely to suffer poor outcomes? So that's something that we're really keen to look at as a piece of work and project. We have access to interpreters and a very robust interpreting service in terms of that instant feedback and communication with women. And we also have different processes within maternity in real time, such as fresh eyes review. So this is where a midwife who's caring for a woman will have a colleague come in to assess independently what's happening in that room at the time. So there is that, not to double check essentially, but a colleague to verify what is happening in the room. We've had feedback from our BME groups independently of NUH, and I think it's fair to say there's definitely work to do. In terms of access to maternity services, is it in the right place? We still work in a very traditional model, certainly in community. Mary Potter Health Service is a fantastic facility and does reflect the multicultural population there. But actually, I'm really keen to look at going into mosques, for example, the cultural centres, to provide maternity care there. I know they've done a successful project in Coventry, for example, where midwifery services aren't provided out of health buildings. They are within those community centres, and that's something that we absolutely have to explore to make sure that women in those groups can access maternity care effectively, efficiently, and so that they do engage, we engage with them as much as they want to. So there is lots of work ongoing, but I think that 5 times more piece of work is something that through national reporting surveillance has come up, and I think it's sadly, and I'm ashamed to say it, that it's taken a long time for all maternity services to recognise that the impact of healthcare on BME women and families. The evidence has been there for many years, but actually to bring it all together actually was around 10 years ago. So it's a piece of work that actually has been slowly coming, but it's absolutely essential. And my philosophy is, if we get it right for our BME women, we'll get it right for all women.
Thank you. Thank you. All right. Councillor Welsh, just one last question, please.
I've a question that has arisen from people contacting me, and I did say I would ask it, and I forgot, so I need to ask it. Weekend care on maternity, in your maternity departments. There has been feedback that there is an issue with weekend care on your maternity departments with regards to inductions and C-sections, that you have lower amount of staff at the weekend during the week, and that is proving challenging and is putting women sometimes in a difficult position. Somebody was convinced to have an induction. They said they were convinced to have an induction on the Thursday because it was described to them, we don't want you to have an induction on the Friday because we want you to have the baby before the weekend. For example, is there an issue with regards to weekend care in NUH? Is it harder to staff during the weekend? And on top of that, is it a case of if someone comes in for an emergency C-section, say at 2 o'clock in the morning, that's still a problem as well?
Thank you, Michelle. So, actually, conversely, it's we're seeing better staffing, certainly on Saturday and Sunday nights because of the premium pay. So, so actually, we're seeing the converse. In some cases, we don't have routine elective sections at weekends. It is a Monday to Friday service, and that is expanding. As all maternity service, we manage our flow and our activity as much as we possibly can. And so inductions is one of those semi-elective procedures, if you like, where it is subject to what's happening at the time. And we can't control who's coming in. If we've got an influx of women in spontaneous labour, they will always take preference for that more planned and that induction, and we recognise that it's not the best experience for women if there's a delay, but actually it's all done through a safety mechanism. We have, as I've said before, we have that cross-site meeting at 9:30. I chaired the one on Sunday, for example. So there is senior cover, 8A matron and above, that chairs the weekend meeting, because we recognise that some of our band sevens probably didn't have the experience, and I thought it was really important that we have a senior presence at a weekend. And so for our on-call, we have a manager on call on Saturday and Sunday for any issues and concerns, and it is 8A and above. I'm part of that rota as well, to support our staff and teams. We have increased our consultant presence across both sites as well. So there is a consultant physically in the building on a weekend, at least 9 till 6, if not later, and then they're on call. So they're, as all NHS services, when we talk about, actually, it's for some very, very complex care, it is safer to have your baby Monday to Friday, because actually it's not just about the maternity team. It's colorectal, it's the interventional radiologists. It's far bigger than just midwives, doctors, and neonatal services. So there will be occasions where we really want to manage that care and do things on a Monday, Tuesday, and not leave it to chance on a Saturday, Sunday, where we can pull the team in, but they're not physically present. They're coming from outside of the unit. So there will always be those occasions, but it is a 24-hour service. We do have operating theatres that run 24 hours a day. Maternity, a theatre team will come to us as necessary. So, yeah, does that help? Thank you.
Thank you. Well, thank you very much to you for answering those questions. I am going to ask you, we've obviously discussed what the recommendations are, which were to listen to the update on the information regarding Donna Ockenden report and to see what progress you've made. Could I ask, please, Sharon, that you've referred to serious incident backlogs being cleared by the end of March 2023. Could I have a written update in April, please, to tell us where you are and how you're doing? Was that possible? And members, we've had a lot of questions, we've had a lot of information, and I can't really keep the people from NUH any longer. I'm sure they've got to go, they've got appointments this afternoon. We have a 45-page briefing here from Lisa. I've been looking at it. You've been to endless trouble, Lisa, to produce this document. But members can read it, and we have had, I think it was two cycles ago, we have had a briefing on winter pressures, and clearly your winter pressures are going to change over the next few weeks, I would have thought, because we have bad weather threatened, we have strikes with nurses, strikes with ambulance, strikes with doctors. So whatever winter pressures plans you have in place, I would assume that these could change owing to what is happening. As members know, we're starting again at 2 o'clock with access to GPs. So if members agree, I'm going to thank Anthony, Michelle, Sharon, Lisa, and Rosa for coming this, and Sarah for coming this morning for this meeting, and anybody is welcome this afternoon. But I am concerned if we start the winter pressures now, you are not going to get back to your afternoon business, and I don't think that's fair. So, do members agree that they can read the winter planning paper here? Thank you, Lisa. You put a lot of time and work into that, because we must start at 2 o'clock with the access to GP surgeries. Yes, Michelle.
Sharon, I think this is one of the biggest, most important things affecting the people of Nottinghamshire. And while I don't want to keep them any extra, I think we need some reassurance from you that this isn't going to wait until the next health scrutiny committee. Every person I speak to when I go door knocking, there's a problem. I think we need to discuss it as a scrutiny committee. I don't think it's acceptable just to read the report. That's my own personal.
Anthony, do you
opinion.
have a comment on?
What I was going to suggest, Michelle and committee, is that we discuss during the work programme item how best we can get this into our programme to give it the time that it deserves. And I take on board exactly what you're saying in respect of end of March. But what we don't want to do is to start something that we can't finish. And we do have GPs attending at 2 o'clock that they can't change their times, and they've been generous with their time, as Anthony and his team have been this morning. So if we discuss that in slower time during consideration of the work programme, we can then let you know how we want to proceed, if that's okay.
If when we come to discuss it this afternoon that you feel from the 3 items we've got on whatever date it is, you want to extend, we'll have to extend the day again. But it's only because we get so much information and so many questions to ask that this happens. If you weren't coming up with questions, they would be over in an hour. But you're coming up with questions which are very, very important. No, they're very important questions, and therefore it's difficult to alter that timing. So we will bring that up in the work programme. But Anthony, would you like to make a comment?
We're in your hands. Michelle and Sharon need to go, but Lisa and I happily stay and answer any urgent questions on the winter plan. Equally, Lisa will be happy to take questions offline, and then if you want us back to talk about how things have been this winter and what we're doing to prepare for next winter, we'll come specifically on that item at a future meeting. So there's
you want to go ahead with it now?
I think there's some urgency in here.
Pardon?
What are we going to do about the other items on the agenda as well? If that's the case, if we're going to knock them on further and further.
We can't, because we've got the GPs coming.
Yeah.
So could I just suggest that the way Andy's described it, you have a brief discussion now. You still have a brief break, so members can grab a bit of lunch before the 2 p.m. item. So if we allow the people who are due to leave,
if Michelle and Sharon can go, because Michelle's got to attend a meeting for me later on this afternoon.
You two ladies go.
Needs to get away, and then we're happy to spend the next 20 or 30 minutes, depending on you, Chairman, answering urgent, the important
questions. Thank you, ladies, very much, Sharon, Michelle.
We'll
Lisa, you're staying, right? Sharon and Michelle, thank you very much. I'm sure we'll see you again in the not too far distant future. Thank you very much. Thank you, ladies. Over to you, Anthony.
Okay, I did have a preamble prepared, but time is tight, so I'm going to pass on to Lisa.
And likewise, I'll take the paper as read and just pull out a few key points so we've got as much time for questions as possible. So what you've got in front of you is the NUH, a very brief overview, and then attached in the appendices is a more detailed winter plan for NUH. And I thought it was helpful to add the integrated care systems winter plan. I know that you've had Amanda and other colleagues from the ICS here previously. So I think that the important thing is that we are as joined up together as possible in our approach to winter. So in the overview, it sort of describes the context. So we were coming out of the pandemic going into this winter, and and there were a number of unknowns for us, so we couldn't just look back at previous winters in terms of our planning. So we had to remain really agile in our approach to that. The focus absolutely is patient safety, and trying to get the right patient to the right place at the right time has really underpinned our work, and so too has the health and well-being of our staff. So recognising where they've been over the last couple of years and heading into another winter. We were absolutely expecting a flu season this year in a way that we hadn't seen it before. As we came out of the pandemic and we all took our masks off and stopped washing our hands as much, we knew that we would see a resurgence of that, and certainly we saw that in Australia, and we were tracking that on the other side of the world to understand what that would mean for us. We had two bed models that we worked up across the system, and the first one was a nominal state, so a kind of fairly reasonable winter. But actually, what we quickly moved into was the more challenging winter bed scenario. So at our peak, we had nearly 200 patients in the hospital that had flu, and on top of that, we had over 100 patients with COVID. Operationally, that means we've got to keep people segregated and isolated and move them through the organisation in a more complex way to keep them safe. So that did present a number of challenges to us. And you'll see in here described a number of critical instances that we declared either as a hospital in isolation, or sometimes they were declared as full system incidences in order to respond to the urgent and emergency care pressures. And that did have a knock-on impact on our planned care and our elective care. So despite the backlog of planned care we'd got and the plans we'd got going into the winter, actually, once we got into the middle of December and we saw that volume of flu patients in the organisation, it meant that we had to turn some of that elective capacity, so some of those beds, 3 wards worth of beds, over to managing our emergency patients coming through. And then on top of our winter plan, in that kind of agile state, we have needed to introduce a number of new ways of managing patients. And we've touched on those a little earlier today. So things like the NUH at home model, virtual wards that Anthony mentioned, where we retain the responsibility of the care of the patients, but we treat them in their own homes. Increasing that same day approach. So how do we get the diagnostic and the treatment package all together concentrated as quickly as possible, again, to get the patients home and make sure that we're using all of our available resources as well as possible. We also were recipients within Nottinghamshire of some additional funds over this winter that was specifically focused on helping discharge. And as Anthony described, we have a role in discharge. The vast majority of people that leave NUH are what we describe as simple discharges. They are patients that are going home and don't require any additional support. But there are a proportion of patients that take up a disproportionate amount of the bed base, as it were, because they stay longer in our hospital, who require support from either local authority colleagues, sometimes from the third sector, or from community colleagues. And we've had to work in a really agile way to expand that capacity. So sometimes that's about recruiting more people, sometimes it's about obtaining more nursing and care home beds across the county to be able to accommodate those patients. And sometimes it's about how we do things differently. So at NUH, we have developed this winter an integrated on-site discharge hub. So all of those different partners across the health economy are physically on-site at QMC, and working together for any of those referrals coming in, so that there's a multidisciplinary review and therefore hopefully an improvement in flow out of the hospital. But it's fair to say that that number has not improved to the way we would like. So as we sit here today, there's about 180 patients that we describe as being medically safe and ready to leave hospital. But there are a number of reasons why their discharges aren't going to happen today. So there's much more work and more learning for us to do. But if we hadn't been able to adapt in the way and work as we had as a system, then that number would be much greater than it is today. I'll stop there, and I'm happy to pick up any questions.
Councillor Phil.
I've got loads of questions, honestly, but I'll pick the one that I think's probably the most pressing and most important. Come back to this later. I'm just interested in that kind of transition between health and social care, because it's something that crops up a lot in our world as well as yours, as I'm absolutely sure. What concerns me, and this came out as well about the integrated partnership meeting that kind of we attended, and I can see an awful lot of goodwill in the room, but I couldn't really see any real shift and recognition from health that actually we've got to kind of fund social care properly, and it's got to be in partnership with health. And I didn't see that happening in that room. I didn't see it. So this is an ICB type question, and I just what jumped out at me, and this might be just my suspicious nature. If so, I apologise. But on page 60 of 122, there's some bullet points, and it's talking about the discharges. Okay, so it's just under the further funding has been approved nationally to increase discharges during week commencing the 9th of January, in addition to the BCF funds. I presume that's the Better Care Fund, to create further system capacity, and a 1.67 million to create additional interim bedded capacity. Why did that money and that funding not go to social care?
Some of it did, Kate. So there are, and Rosa might be able to comment on this. So there are 2 or 3 different strands of funding, some of which came in winter, and I think that's probably one of them you've just quoted there. Some of which were announced as being for the financial year 2023-24 and 2024-25, and they are designated as for discharge, and they'll either be administered through the Better Care Fund, or they'll come directly to the council. Melanie, of course, will be able to advise you on how the council will administer those funds, because you might use them in the market to stimulate market and ensure that people have appropriate pay and so on. You might use them to do training. Those are things that eventually, if we do enough of them, will grow a resilient care market and help the discharges, because it gives us more placements and a more resilient approach. So some of that money will have gone to social care. Critically, in year 22-23, the ICS at risk, and bear in mind that our ICS publicly set a deficit budget, so it could invest in this, pulled together an £8.5 million integrated discharge fund, some of which went into things like our discharge hub in QMC, which is multi-agency, some of which went to support social care markets and so on. So the money is divided across the system, and ICB acts as the broker to make sure that each partner gets its fair share based on business cases and what those business cases will achieve.
And can I just add to that? Sorry, because I think Lucy, Downton and Amanda came either last time or the time before to talk through some of those system winter plans, and I'm sure they would be happy to come again to talk about how that role of ensuring that funds are both allocated and then the impact understood and fed into planning for next winter happens. But exactly as Anthony has said, some of that money has already gone to look at things like fee uplifts for home care providers that we know then has an impact for everybody in the system in terms of supporting, some of our discharges. But the detail on that is purposefully not in the paper today, which is very focused on NUH's efforts around winter planning. But I'm sure Amanda and Lucy would happily return to have that conversation again with members if it's wanted.
Thank you. So we've had Rosie, because you indicated. Does anybody else wish to speak to this? Right. Well, clearly you've got a month ahead, I suppose. Depends what the forecast is over the next couple of weeks. So can I suggest, Anthony, that perhaps, I don't know, you suggest in a couple of months you come back and tell us how you've coped with it, just in case you've had critical incidents and things like that. And then we can at least see whether your best laid plans came to fruition, really.
Yeah, very happy to do that. And I'm sure the colleagues from the ICB will come along and talk through how they intend to allocate that additional funding, Kate, and how that will get divided across agencies. And of course, we can also tell you how we're getting on with that broader urgent and emergency care strategy. We hope to have finished our first draft by then, which is our means of trying to tackle this a bit more sustainably. Just one point about whether money would transfer from health into local government and social care. For example, I think the mechanism for that is the Better Care Fund, and the money comes down rather than between organisations, because in the Nottinghamshire system, the health service has set a deficit budget for 22-23 has yet to declare its budget for 23-24. So our best bet in terms of integration and working across the system and making sure that social care plays its part in that is that additional funding that is dedicated for discharge. just our best means, I think, of getting that cross-sector working. It isn't the only source of funding. Quite a lot of things that we would do in NUH and have done for many years are partnership related. We have people in the trust that focus on this every day and have done so for a number of years, because problems around discharge are not new. Back in the days of Sir David Pearson, we were hammering away at this. The new money, which is actually substantial new money depending on how you look at these things, is in 2023-4 and 2024-5.
Thank you, Anthony, and thank you, Lisa, for that. And sorry that you. Oh, wait a minute. Sarah wants a word.
Yeah, just a quick one really on that point of funding. Obviously, in the report it mentions some of the mitigations being delayed because of the speed of sign-off. And I know within the Better Care Fund, there is the money that comes obviously through NHS England, and the timescales. And I think it's something that quite concerns me. I sit in the city on the commissioning subgroup for Better Care Fund from a Health Watch Scrutiny perspective. And what really has concerned me is the speed in which commissioners have to put together plans, coming up with things that, basically, I know it's done with a lot of skill and a lot of knowledge, but it does feel like the timescales are very patchy, and put a lot of pressure on people to get it right. And then the sign-offs have been retrospective because of the timescale. So this is an issue, I think, for us in terms of future winter pressures, is that, most of us have sat around hearing about winter pressures a number of cycles in this committee and other places. And it seems to me that each year we sort of start talking about it as if it's never happened before. And I feel like we need to really capture the learning and start being proactive at an earlier stage, particularly by speaking with NHS England, having obviously the support from the ICB. But from a scrutiny point of view, I think there's something there that really does challenge our system if funding isn't flowing and plans are having to be made in a very rushed way, it seems, because to meet the demand of some funding that's coming in. So I do feel that we need to have a better overview of that from a scrutiny point of view, to understand the processes around funding, where they are going, but also, is there anything we can do as a committee to support the mitigations of late approvals and other things, so that we can raise that in our different departments to try and support the mitigation of money actually getting where it needs to be. So I just wanted to add
come
that.
back on that.
Yeah, so I completely agree. It was the same when I worked in local government, that funding could be somewhat lumpy. One of the ways I think we're going to try and mitigate that in NUH is through that long-term strategy, because it's somewhat of a misnomer to say that it's just about winter. As I said earlier, that we've been busy year-round, particularly since COVID. Although there is a relationship between people that attend and how long they stay, which we haven't got time to go into today. Working with our ICB colleagues, would hope to smooth that and anticipate some of that lumpiness. And in defence of our local system, that £8.5 million integrated discharge budget was done at risk, and did put the system into deficit and got it into hot water, actually, with NHS England. So I think the system here has been brave in that respect. But I do take your point about the sort of boom and bust nature of the money.
Thank you very much. And with that, Anthony, I'm drawing your part of the meeting to a close. Thank you very much for you coming. You're welcome to come back anytime, and we shall see you not too many months from now. Pardon?
No.
So thank you very much. Members, we will continue at 2:00 with this afternoon's access to GP. And thank you, Rosa, too. Are we seeing you this afternoon? Right. And Sarah, will we see you this afternoon? Thank you to the press on the back. Thank you to the press. And thank you, everyone.
If we can stop the broadcast.